Good morning, everyone. We at Dr. Lal Path Labs extend a very warm welcome to all of you to this CMA today, which is about revamping of the lipid profile. The topic for the CMA is empowering heart health, a focus on lipid profile. This CMA is organized by Dr. Lal Path Labs under the aegis of Association of Medical Biochemists of India, Delhi chapter, and Lipid Association of India. The objectives of the CMA are fasting lipid profile, belief driven versus evidence driven. So, is fasting mandatory for lipid profile? Will be discussed. Future of calculated and direct LDL cholesterol in an era of non-fasting lipid testing. ASCVD risk step towards healthy heart tomorrow. This CMA has been awarded credit hours of 2 hours and 40 minutes by the DMC. I now invite the dignitaries, please come up on stage for the auspicious ritual of lamp lighting. I request Dr. Chanda, Dr. Arvind Lal, Dr. Vanna Lal, Dr. Raman Puri, Dr. Dinesh Puri, Dr. Iyengar, and Dr. S.K. Gupta. Please come up on stage, sir. Lamp lighting, as we all know, is a bow down to knowledge, a tribute to Ma Saraswati, to bestow her blessings and invoke the waves of knowledge. It also means keeping the waves of knowledge generated on this stage constantly active through the medium of the flame of the lamp. Thank you, everyone. I request all the dignitaries to please remain on stage. We have an important announcement to make. On the occasion of this CMA today, we have an important announcement to make. Dr. Lal Path Labs is pleased to announce the launch of the Cardiology Division Cardio Pro. Dr. Lal Path Labs Cardio Pro division provides an extensive menu of cardiovascular testing, from routine lipid evaluations to complex genetic studies, to support the spectrum of clinical scenarios that are faced by clinicians each day. I request the dignitaries to please unveil the cardiology test menu booklet as a symbol of the launch of our Cardio Pro division. So you please come in front of them, please come this way. Thank you, everyone. You may now take your seats, please. Now I invite Dr. Arvind Lal for opening the session.
Good morning, ladies and gentlemen. I welcome all of you to this very important CME, Empowering Heart Health, a focus on lipid profile. I would like to thank our partners, the Lipid Association of India, India, Delhi Medical Association, eminent speakers and expert cardiologists and chemical pathologists from India and abroad that include Dr. S.S. Iyengar from Bangalore, my senior from college from AFMC, Dr. Raman Puri, Dr. S.N. Narasingan, Dr. Devki Nair from London, Dr. Anuj Prakash, Dr. Vinod Vijan, Dr. Aziz Khan, Dr. S.K. Gupta, and Dr. Seema Garg. And I also thank the members of the Dr. Lal Path Lab team who have made it possible. Dr. Om Manchanda, our Managing Director, Dr. Sanjay Arora, our Group Medical Director, Dr. Nimmi Kansal, Technical Director for Clinical Chemistry and Biochemical Genetics, Dr. Reena Nakra, Principal Director, Lab Management and Technical Excellence, Dr. Ratima Kohli, GM Sales and Marketing Genomics, and Dr. Kamal Modi, Senior Consultant Biochemistry, and all the others who have made it possible today. Thank you very much. Traditionally, we are used to commonly hearing about elderly people in our families or in our neighborhood passing away due to a heart attack. However, what is emerging as a major concern is the sudden death of young adults in the mid-30s or even earlier to late 40s due to a sudden cardiac arrest who were otherwise healthy and even athletic. Also in the news these days are heart attacks amongst Indian celebrities like popular singers like KK and TV actors like Siddharth Shukla and Raju Srivastava. Also in this elite list is the vivacious, glamorous former Miss Universe Sushmita Sen, who luckily survived a massive heart attack and about 95% blockage in one of her arteries. 2 days ago, on the occasion of the World Health Day, Dr. Devi Prasad Shetty, the famous Indian heart surgeon in Bangalore and now in rest of India, has written a very thought-provoking article where he talks about how no heart attack actually occurs suddenly, but is the result of slowly happening cascading effects of some kind of pathology that could have been detected with early screening of basic parameters, even at the so-called routine diagnostic labs near your homes. This can prevent emergencies that land you at big heart hospitals. I often say on a lighter note that you would rather prefer to be my patient than being Dr. Naresh Trehan's patient, because if you're Dr. Lal's patient, there are very high chances of you being able to reverse the pathological changes pertaining to your heart. But by the time you land with Dr. Trehan, usually it is a one-sided story of a triple or a quadruple CABG. In the last few decades, India has witnessed a major epidemiological shift in the burden of diseases. While we are still struggling with the control of infectious diseases, the non-communicable diseases or NCDs or lifestyle diseases are now responsible for more than 65% of deaths in our country and elsewhere also. The major NCDs in our country today are diabetes, hypertension, heart disease, cancers, pulmonary diseases, liver and kidney ailments, and stroke. Cardiovascular diseases, CVDs, are the leading cause of mortality in all parts of India and are estimated to account for nearly 1 in every 4 deaths by 2030. Currently, about 30 lakh people die each year from heart attacks and strokes in India, and CVD strikes Indians a decade sooner and have poorer outcomes as compared to their Western counterparts. Further, piling on the bad news, diabetics are found to be twice more likely to get heart disease. And India is infamously the diabetic capital of the world, estimated to have nearly 7 crore diabetics by 2025, not to talk about the so-called silent heart attacks in diabetics. But a double whammy is also due to a very high number of hypertensives in India. One estimate says that there are 18 crore hypertensives in the country, and another icing on this horrible cake is the form of a diabetic also being a hypertensive. Hypertension, diabetes, hyperlipidemia, genetic susceptibility, lifestyle practices like smoking, alcohol abuse, stress, obesity, and a sedentary lifestyle are the key risk factors for heart disease. Like all NCDs, heart diseases result from an interplay of genetics, lifestyle, and environmental factors. However, the European Society of Cardiology and several other credible publications have concluded that poor lifestyle is a greater contributor to heart disease than genetics. Now, you can't get away by saying that my father had it, my grandfather had it, therefore I got it. It is because of your poor lifestyle, especially in case of premature heart disease in the young population. And as we were discussing, Dr. Ramanpuri was telling me that the lipid profile testing should be started as early as 20 years of age. So therefore, adopting a healthy lifestyle should be a top priority for reducing heart disease, especially in those with family history of heart disease. The second important priority is early diagnosis. Today, modern medicine and technology have enabled clinicians track specific biomarkers to comprehensively assess heart disease, identify the risk of heart disease, and accurately detect heart attacks, especially now with the advent of artificial intelligence and machine learning. The lipid profile has gained popularity amongst clinicians as a recommended test panel for identifying lipid and lipoprotein abnormalities, which are a major risk factor in heart diseases. It is my pleasure to share with you Dr. Lal Path's labs was the first lab to coin the term lipid profile in India when I introduced HDL, LDL, and VLDL cholesterol in addition to the total cholesterol and triglycerides back in the early 1980s. The reagents for HDL cholesterol were not available at that time, and I had to do the test manually using several different methods. For example, magnesium sulfate precipitation for chemical extraction of HDL cholesterol, calculation of LDL cholesterol by the traditional Friedewald's formula, and using electrophoresis, which ultimately became the technology for the introduction of quantitating HDL, LDL, and VLDL cholesterol. This book cover, which I am showing in front of you, Corporate Yogi, this book was released about 5 years ago, in which it is actually about my little bit about my life and also about my spiritual life, in which I took this problem to my guru, who is no longer in physical form right now. And I asked him this question, that these are the two methods which are available to me. One is the precipitation by magnesium sulfate of HDL, and the other one is electrophoresis. So I was trying both of them and reaching nowhere. And he said, try electrophoresis and you will reach, and we never looked back. And any one of you who would like to have this book, please let us know, let Ratima know, and I'll send you this book. You will actually read about this. I've written about this, that I was actually tapping here and there. And well, for a minute, such gurus, he also made me, we also introduced lots of radioimmunoassays, and many of them, including thyroid, of course, for the first time in a private lab. We also did a lot of infertility testing. And there were people who were coming to me for infertility tests. The males, sperm count was slightly low, normal, or whatever. The woman seemed normal. And so he told me one day, he says that such people should be sent to me. And I've got 100% result. Sent doctors from AFMC, sir, two of whose wives were gynecologists who help, other women, produce children, couldn't produce their own. And this I call in my book as a cosmic IVF. So please read about it. One such beneficiary is Priyanka Chopra's brother. I mean, he was born with this therapy. Going back to our world of lipid profile, So I must share with this distinguished audience that prior to the launch of HDL cholesterol electrophoresis, we had for many years been carrying out agar gel electrophoresis and staining the slide with oil red O. This distinguished the lipoproteins into beta, pre-beta, and alpha, if you remember, sir. And obviously, this qualitative assessment made little sense to the cardiologists, but we had to persist with it till we introduced the HDL cholesterol electrophoresis. The pattern of dyslipidemia in India or with Indians is very distinct as compared to the Western populations. Indians tend to have higher triglyceride levels and lower HDL cholesterol combined with small, dense, or heavy LDL particles measuring below the size of 260 angstrom units, a pattern known as atherogenic dyslipidemia. We did hundreds of such LDL subfraction electrophoresis tests till such time the reagents were stopped by the Japanese company making them, and all our efforts to indigenize this test were unsuccessful, and even the biomedical department of IIT Delhi threw their hands up in air in exasperation. Am I right, Dr. Nimi? There you are. And by the way, we launched LDL subfraction electrophoresis right in this room in 2004 with Dr. Bajaj chairing of All India Institute and Dr. Srinath Reddy there. And my old friend, Dr. Parvez Ahmed was also here. So we launched with much pomp and ceremony, and the test was withdrawn because of the non-availability of the reagent. As the pioneers who have been credited with introducing several essential tests and testing methods in India, we took it upon ourselves to go around the world looking for solutions to bring newer parameters in the lipid profile testing to the masses. And LP small a, lipoprotein small a, is one such test that I really had to look with a magnifying glass all over the world, and we finally found it for the first time. And finally, it is heartening to see where we have reached today. Not only are we able to do a comprehensive non-fasting lipid profile with apolipoprotein A, apolipoprotein B, or A1 and B, I would like to inform this august audience that when this test was introduced in the 80s by Boehringer Mannheim, it was touted as a biochemical angiography. You remember, sir? Much pomp and ceremony again, apolipoprotein A1 and B being launched in India as a new biochemical angiography test. It's in print. And lipoprotein A and high sensitive CRP and serum homocysteine were all today able to estimate the 10-year risk of having cardiovascular problems with the ASCVD or atherosclerotic cardiovascular disease, which our cardiologists are going to be talking about now. Other related tests which we introduced for the first time in India, including the N-terminal pro-BNP, high sensitivity troponin T and troponin I, replacing the earlier CPK, CPK-MB, and LDH. And you cannot imagine that when we launched simple tests like CPK, LDH, and CPK-MB, etc., the physicians in Delhi were ecstatic because there was nothing, like these tests seen before. And one such benefactor was Dr. Ian Malvia. For his own purposes, he loved these tests, and he still does. In addition to, what is that, aldolase, etc. So, other tests like ceramide, plasminogen activator inhibitor, or PI1, fibrinogen markers of coagulation, pharmacogenomics panel, cardiometabolic panel, insulin resistance combined with NAFLD4. Also, advancements in radiology like the CT angio of the heart have made possible detection of even very small blockages much before they grow and cause heart attacks. The effectiveness of this is truly remarkable, especially when no blockage is detected, and it goes without saying that any small blockages are then subjected to a conventional angiography in a cardiac cath lab. But this has so much of potential, and I have no idea why it has not picked up in India, maybe because of the cost. So I mean, internally we have been debating about it, that if we ever get into radiology, should we or should we not get into this CT angio? I leave it to you to advise us. Heart disease is the #1 killer disease and a major NCD in India. And premature deaths and DALYs, that is disability adjusted life years associated with NCDs, result in 2% loss of GDP in the country every year. However, these can be prevented to a large extent by making people aware of making the right lifestyle changes and with early detection through preventive and wellness testing regularly. Through the deliberations in the CME today, we should try to identify if any new tests which will help in early diagnosis of heart disease are available, which can be used in the effective management of cardiovascular disease. Please keep in mind that the tests which are available today were brought in more than 40 or 45 years ago. And one such test which we have been again debating internally, and I think Dr. Nimi has talked to Dr. Ramanpuri many times, is the omega-3, omega-6 fatty acid ratio. I would also like to inform many of you a little bit some facts about our lab, Dr. Lal Path Labs. So we are a lab which is the oldest pathology lab in the country, having been founded by my father in 1949. Right behind this hotel, Hanuman Road. In fact, I was born there. And the lab still exists. It was shut down for, reasons of some other thing, but we have shifted the lab now to Rohini, which is the biggest lab in Asia. So today, my father brought in cholesterol and triglycerides. And I brought in the HDL, LDL, and the other, such tests. And there are hundreds of tests which we introduced for the first time in India. And today, we are running 277 labs all over India. We run 5,000 collection centers. Last year, I don't know how last year's results so far, we tested nearly 2.75 crore patients, which means that in one day, we can test easily more than 100,000 patients. And we are still the #1 lab out of a plethora of 3 lakh labs in India. We're still #1, both in top line, bottom line, number of patients, number of tests, and we also run the biggest histopathology department in the world. We test 1,400 biopsies a day. And we are the only ones on this side of the Suez, as they say, who have 2 electron microscopes for kidney disease. Thank you very much.
Thank you, sir, for sharing your insights into Dr. Lal Path Lab's focus on lipid profile. I now hand over the proceedings to Dr. Himanshu Mazumdar for moderating the scientific sessions. Over to you, Dr. Himanshu.
Thanks, Archana. Once again, I welcome you all to this CME entitled Empowering Heart Health, a Focus on Lipid Profile. Let's spend our Sunday in this scientific extravaganza, including 5 topics on different aspects of lipid profile to be delivered by 5 of our eminent speakers. So for the first 2 sessions, I would like to introduce and welcome 2 of the eminent clinicians, Dr. Vinod Vijan and Dr. Aziz Khan sir, to moderate the first 2 sessions of today's CME. So Dr. Vinod Vijan is the senior most reputed interventional cardiologist from Nasik, Maharashtra. He is the owner and director of Vijan Hospital and Research Center, Nasik. He is a recipient of IMS prestigious Dhanantari Award and got recognition with Icon of Echocardiography in India Award, Lifetime Achievement Award, and USA Cardiologist of Indian Origin Award for promoting cardiology in India. He is also a life member and a fellow of most cardiology, physician, and critical care societies. He has pioneered and introduced many state-of-the-art diagnostic and therapeutic technologies in his center, which are as comparable to the best in the country and beyond since 1987. Our second moderator for the first 2 sessions is Dr. Aziz Khan, MD DM Cardiology, who is a renowned cardiologist in Nagpur and director of Crescent Hospital and Heart Center, Nagpur. He is awarded with Fellowship of American Cardiology in 2005, European Society of Cardiology in 2015, Society of Coronary Angiography and Intervention. He is the principal investigator at various global trials. He has presented and published about 60 scientific papers in different national and international conferences and journals. He has also contributed a number of chapters in different cardiology update books. He is regularly participating in health camps and educational activities like lectures on prevention of heart disease. So I would like to request Dr. Vinod Vijan sir to introduce the first speaker of today's scientific session, Dr. Raman Puri, Chairman, Lipid Association of India.
Very good morning. Am I audible? Am I audible? Hello? Am I audible?
Yes, sir.
Yes. So, good morning, Dali. It's indeed a proud privilege and honor to chair the first session. And my apologies for not making it physically because of commitments. And it is an equal honor even to have heard Dr. Lal, but maybe I've heard in the past. And now, again, a proud privilege to introduce my senior colleague and a very good friend, Dr. Raman Puri. They say the greatness of a person lies, in his simplicity. So when I asked for introduction, he just put it that, very simple, this thing that a senior interventional cardiologist, cardiac care, New Delhi, founder chairman of Lipid Association of India, former HOD, Safdarjung Hospital, cardiology, and member of International Lipid Expert Panel and IS Regional Federation Asia Pacific. But as a chairperson, it's my privilege to, I would just say, since I've known him, just last month, he set the whole audience, almost I would say, on fire with his very fiery speech on Lipid Association of India guidelines in New Orleans, which is parallel to the American College of Cardiology. Such eloquently he spoke that the Association of American Cardiologists of Indian origin have even consented to form their chapter of LAI. So imagine when we were going to US to form our Indian chapter, now the Americans are forming a LAI chapter and they have agreed. And this is what I had communicated to sir. And the whole hall was hearing him with rapt attention, and the only noise was extra tables and chairs being pulled in, a full hall with even so many cardiologists standing. So this speaks of a person, I would say, in fact, when I'd introduced him as the father of lipidology in India when he had come to Nasik, sir had, said, being very polite and humble, not to write, but I said, it's my privilege. So without coming much between us, he is going to talk on his subject in which I think there is no better authority than him, because lipidology, I believe, is in nucleus, cytoplasm, mitochondria, and you name it. So Dr. Raman Puri sir, LAI consensus in the year 2020, though I know that we are having even 22 guidelines and 23 also coming. Welcome, sir. Dr. Raman Puri, I saw him in the audience.
Good morning, everyone, and respected Chairperson Dr. Vinod Vijan and Dr. Aziz Khan and Padam Shri Dr. Arvind Lal. And thank you, Dr. Vinod, for kind words. But this is more than what I deserve, actually. And now coming to Indian lipid guidelines, so my talk will be basically two. One, that why we need our Indian guidelines when there are American guidelines, European guidelines, And second, how it is different from these guidelines. Now, regarding Indian perspective, Dr. Arvind Ral has already talked about this in detail, so I'm not going to go into further detail. Only I say that we have higher prevalence of premature coronary artery disease, and we have higher chances of dying of coronary artery disease as compared to Americans and Europeans with the same degree of coronary artery disease. And based upon that, even American Association has, ACC has also, labeled South Asian as one of risk enhancer. Means if you are South Asian, your chance is one of the risk factor for coronary artery disease. If you look into the CVD mortality in United States, it has shown a tremendous fall of more than 50%, and credit goes to the American guidelines. And also there is a more than 50% reduction in European community also, and thanks to European guidelines. And the targets have been changing. It was 1980, 2000, in 1988, it was less than 130. Then it was brought down to less than 100, and then it was brought down to less than 70. And less than 70, we have been following for many years now. And with these reduction in targets, there were further reduction in cardiovascular mortality. Look into what we are facing. Despite all of us following American guidelines and European guidelines, there is 41% increase in CVD mortality from 1990 to 2015. So that is an alarming number, and we were all worried about it. So what are the possible reasons why we have higher incidence of coronary artery disease? One of that is that we have a high prevalence of atherogenic dyslipidemia. That is, characterized by increased triglyceride, low HDL. LDL is either normal or mildly raised. There is increase in small dense LDL particle, and also there is increase in lipoprotein A, because 25% of Indian population have elevated lipoprotein small a. And in addition to that, we have a genetic predisposition also, as Dr. Arvind Lal said. But of course, whenever there is a genetic predisposition, there is a triggering factor which makes, it manifest, like physical inactivity and other, diabetes and hypertension can do it. There are a number of other reasons also. And even, inadequate control of hypertension, diabetes, all these are contributes to early manifestation of coronary artery disease. And never forget, our dietary pattern is very bad. We consume a lot of oil, and we consume a lot of trans fat also, because we're all fond of pakoras, samosas, chole bhature, and that is nothing but trans fat, because the person who is making it will use this oil again next day, put it on chana and all that, which will be given to us. So that is, and that increased trans fat decreases HDL cholesterol, and it is said to be lethal for us. And another is lifestyle, as Dr. Arvind Lal said, that sedentary lifestyle the prevalence is very high, and most of us are fond of having an easy life. So based upon this, we had, we thought of coming out with our own expert consensus statement. Now, this is one of the study of lipid profile of American versus Indian population. And here we can find that total cholesterol, LDL cholesterol, HDL cholesterol, and non-HDL cholesterol was significantly lower in Indians as compared to Americans, and triglyceride and ApoB was significantly higher, despite Indians having lower BMI and waist circumference. It's not that only adults you have high prevalence of atherogenic dyslipidemia. This is the original study done by LAI and we published in 2015. At that time, we screened about 2,500 school-going children in the age group of 14 to 18. And at that time, we did extended lipid profile. We included ApoA, ApoB, high sensitive CRP, and TSH in this study. And we found that there was high prevalence of low HDL, high triglyceride, and LDL were around 12%. So that shows that even in second decade of life, being Indian, we have higher chance, incidence of atherogenic dyslipidemia. Now, how ethnicity plays an important role will be, if you understand this slide, you'll be able to understand that we are really prone to have coronary artery disease. This is regarding a 30-year-old Indian who has no risk factor. His blood pressure is 120 by 80. His BMI is normal. If you look into the lipid profile, according to you, this will be one of the best lipid profile. And if LDL is 110, total cholesterol 175, HDL 35, and total cholesterol to HDL ratio 5. If I calculate lifetime risk of this patient, means what is the chance of this patient getting heart attack or stroke at age 80, it is around 37%. There are 37% chances is that this patient will have these, events. Now, if I change this ethnicity from Indian to other ethnicity, keeping all these baseline characteristics same, it becomes down to 25%. So being an Indian, it has, the risk has gone up by 12%. So that shows that there is definitely genetic predisposition in our, because here the total cholesterol to HDL ratio is same. So it is not different in the two groups. So that shows we are more prone to have coronary artery disease. So with these things in our mind, we had we thought of coming out with our own recommendations. Our part one was published in 2016. It took us 2 years to formulate these recommendations. We had about more than 250 experts pan India, and we came out with the recommendations which was published in JAPI. And we classified these patients into 4 groups, which I'll discuss later on. And we recommended LDL cholesterol goal of less than 50 milligram in patients with very high risk group, which included patients with coronary artery disease and diabetes with target organ damage and familial homozygous hypercholesterolemia. 4 months after our recommendations were published, European guidelines were also published, and they said that the LDL cholesterol target should be less than 70 milligram. They made our life very miserable because we are all, like to go what American says and European says, and they started throwing stone to us that you are all doing stupid things. It should be less than 70, but we tried to convince them, no, should be 50, because we are more prone to have coronary artery disease, and we develop heart disease at a younger age. And what we said, less than 50, was not a mere thought process of ours. We had a very strong scientific reasoning for it. These are all important studies which we had, we discussed in detail and formulated these recommendations. In 2018, after 3 years after our recommendations, Odyssey outcome trial results was published. And in this trial, the on patient who was on lipid lowering drug, which included PCSK9 inhibitor, the LDL cholesterol was when reduced from 103 to 53, which near 50 milligram, there was 15% reduction in primary event. So it almost endorsed what we said in 2016, that lowering LDL cholesterol to around 50 milligram or less than 50 milligram is beneficial. Then a year later, after this publication, European guideline also came out with their new recommendations, and they brought down the LDL cholesterol to less than 55 in patients with established ASCVD, which is almost what is similar to what we published in 2016. 50 and 55 is practically same. Then, being, we are very thoughtful persons, like Dr. Anger and all that, because you cannot put all patients of coronary artery disease in one basket. If you look into the IMPROVE IT trial, in which the mean LDL cholesterol achieved was around 53, till 32% of these patients had events in 7 years. And Odyssey outcome trial, again, where the LDL cholesterol was reduced to 53.5, almost similar to what was in IMPROVE IT trial. 12.5% of these patients had event at 4 years. So important point which comes in your mind is that what are the baseline characteristics of these patients who, despite achieving LDL cholesterol of around 50, they still have an events. So this means if they are event at 50 milligram of LDL cholesterol, then LDL of 50 is not a proper target for them, because we have to reduce the events in these patients. And again, we had a lot of meetings around, it took us about 1 year to come out with new recommendations, which was published in 2020 in JAPI. And here, now I'm going to discuss about various ASCVD risk group. Now, the patients in overall can be classified into 5 ASCVD risk group. In those patients who are labeled in low risk group are those who have no or one major ASCVD risk factors. These are the 5 major ASCVD risk factors. If none or one of these major ASCVD risk factors is present and the lifetime risk is less than 30%, it is classified as a low risk group. And those who have 2 major ASCVD risk factor, or those patients with low risk group who has one or more of non-conventional risk factors, these are 7 non-conventional risk factors, or those patients of low risk group who has a lifetime risk of more than 30%, they are classified as a moderate risk group. Those patients who have 3 or more major ASCVD risk factors, and those patients of moderate risk group who have one or more of moderate non-conventional risk factors, they are classified as a high risk group. And in this high risk group, we have another patient group of patients which are classified as other high risk features. Now, those patients of diabetes who have no or one major ASCVD risk factor or diabetes without target organ damage is classified as high risk group. And there are other also TKD stage 3B or 4 patients, familial hypercholesterolemia other than homozygous hypercholesterolemia, extreme of risk factors like those patients with LDL cholesterol of more than 160. Remember, Americans and European consider more than 190 as the LDL cholesterol to be considered very high. But in Indians, since our LDL cholesterol is lower, LAI expert thought that it has to be more than 160 to consider it as a high risk group. And of course, there are other factors, which are included as a high risk features. Then those patients of diabetes with target organ damage, or those patients of diabetes with 2 or more major ASCVD risk factor, they were classified as a very high risk group. And included in this group was those patients with pre-existing ASCVD like coronary artery disease, peripheral artery disease, or cerebrovascular disease, and patients of familial hypercholesterolemia. These 4 groups were there in our 2016 publication. After these extensive discussion post part 1, we created another risk group, which was an extreme risk group. And we further categorized this patient into category A and category B. Category A are those patients of coronary artery disease who have one or more features of high risk group. And category B are those group of patients who have one or more features of very high risk group. So when these patients can be classified like this, then the target changes. Now, for low risk group, the target is less than 100 milligram. And for moderate risk group, it is less than 100 milligram. But in our 2023 update, which will be published, I think this year only, there will be an optional goal of LDL cholesterol of less than 70 milligram. In high risk group, the LDL cholesterol target is less than 70. In very high risk group, it is less than 50. Category A, the target is less than 50, but there is an optional target of less than 30. In category B, the target is less than 30 milligram. There is no optional. You should bring down the LDL cholesterol to the 30 milligram. Now, question you will all ask that why there was a need for an extreme risk group, and why, and from where this number 30 has come. Why not 25? Why not 40? Why not 15? So why you said 30 milligram? Okay, I'll try to justify this. There have been a study which is TRP, secondary prevention TIMI 50 study. Here, there are patients who have stable coronary artery disease. They had myocardial infarction. It was seen that if there are 9 risk indicators which have been there, you can see on the screen. If none of these risk indicator was present, the chances of having cardiovascular event in 3 years was only 3.5%. And as the number of these indicators increased to more than 7, the incidence, the events became 58%. Incidence of event was 58.6%. So you will all agree, I think majority of you will agree, that if the target of patients of coronary artery disease is less than 50, how can you have the same target for a person whose chances of having events in 3 years is 58%? So you cannot have the same, you cannot put these patients, different patients of coronary artery disease in one basket. It's a heterogeneous group. It is not an homogeneous group. Now, I'll give you another example. When the same risk factors indicators were applied to the patients of Improve IT trial, in which all patients were high risk post-ACL, you can see that those patients who had 3 or more of these risk indicators had almost 2.5 to 3 times more event as compared to those patients who had only coronary artery disease. And there was a group in between which had the events in between these two groups, So that is the reason why we created patients, extreme risk group and category A and category B. I'll give you another example. My purpose is just to make sure that you should be confident of accepting the facts which I'm trying to, discuss with you. This is an Odyssey trial, and in those patients who had only coronary artery disease in 4 years, at LDL cholesterol achieved of 53, the events were 8.6%. Only coronary artery disease. when there was associated peripheral artery disease or cerebrovascular disease, the CV event went up to 20%, 3%. And when all three were present, means polyvascular, CAD plus peripheral artery disease and cerebrovascular disease, the events were 26.7%. I think by this time, you are almost convinced. Now, final slide will totally convince you. This is a post-PCI patients who were admitted, had an angioplasty done. You can see that those patients who only had coronary artery disease, they had minimum events as compared to those patients with CAD plus diabetes and hypertension. They almost 3 times more event at hospital 6 months and at 12 months outcome. And there are in group in between like CAD plus hypertension and diabetes. So there means these are the different comorbidities with coronary artery disease increases the cardiovascular event. Now question comes that why target of less than 30 milligram? Why not 25? That again we have a strong scientific reasoning for this. These are all, and I'll try to finish my talk in another 5 minutes. FOURIER trial was a trial in which 28,000 patients of ASCVD were included, and in which the statin, maximum lipid lowering drug, statin plus PCSK9, evolocumab was given, and the mean LDL cholesterol, median LDL cholesterol C was around 30 milligram. From 90 to 30, there was about 15% reduction in primary endpoint. There is a large trial, which is well-accepted trial, that is called cholesterol treatment trialist collaboration. Here in this trial, one of the important observation was that if you reduce LDL cholesterol by 40 milligram, you reduce cardiovascular event by 22%. And if you reduce LDL cholesterol by 20 milligram, you reduce event about 16%. Here, 13% reduction in coronary death and myocardial infarction. Our target of LDL cholesterol was 50. So if I reduce LDL from 50 to 30, these benefit I thought we will be able to get in our patients. We'll be able to reduce around 16% further event if we bring down LDL cholesterol from 50 to 30 milligrams. That was another important point which we considered when we came to number 30. Then we have post-hoc analysis of Odyssey trial, IMPROVE-IT trial, and FOURIER trial, a large number of these patients. And it was found that lowering LDL cholesterol below 30 milligram in IMPROVE-IT trial, around 15 milligram in Odyssey trial, and about 21 milligram in FOURIER trial, there was significant reduction as compared to LDL cholesterol of 70 milligram. And even in Odyssey trial, it was found that the minimum mortality was seen at the level of achieved LDL of 31 milligram. So that also gives us, and we are, as you know, that we're all born with an LDL cholesterol of around 30 to 40 milligram. So that is another important, observations which we considered. Then there are various meta-analysis of statin trial, non-statin trial favoring that. And in FOURIER trial, it was seen that benefit is seen as low as 20 milligram, 10 milligram, 7 milligram. Rather, I can say there is no lower level of LDL cholesterol in which benefit is not seen. And there are some PCSK9 mutations in which the LDL cholesterol is low, and the persons are born with very low LDL cholesterol from birth in the range of 14 to 15. They have been found to have excellent life. They are fertile. They have normal cognitive function, and they are almost negligible coronary artery disease. These were all discussion based upon clinical event. Then we have imaging studies in which you can see atheroma. And it has been seen that lowering LDL cholesterol to less than 30 milligram, there is reduction in percent atheroma volume. In Glasgow trial, 1% almost reduction in percent atheroma volume. Remember, if you reduce percent atheroma volume by 1%, you reduce event by 20%. And then subsequently, we have two powerful trials which have been published recently, Ackman MI trial and Huygens trial, again in which the LDL achieved cholesterol was 24 milligram and 28 milligram. It was seen there was significant reduction in percent atheroma volume. There was significant increase in thickness of fibrous cap, and also there was decrease in lipid core burden index. 1 year after our recommendation, National Lipid Association of USA also brought down, created an extreme risk group in which they recommended LDL cholesterol goal of less than 30 milligram in patients with CAD and diabetes, almost similar to what we said, though I was also one of the author of this publication. And they're very, in their document, they have written that they have taken from Lipid Association, they consider our recommendations and they incorporated these recommendations in their statement. And of course, statin and lowering LDL cholesterol down to 30 milligram is absolutely safe, because now we have a 4-year trial, which is about 7-year or 8-year plus now. Mean LDL cholesterol is 28. In 8 years with LDL of 28 milligram, there were no adverse effects, either because of the drug or because of lower LDL cholesterol. So this is the comparison of LAI recommendations and other international guidelines. Thank you very much for your kind attention. And regarding ApoB, Dr. Iyengar is going to speak in detail, so I'm not talking about it. And few words about high sensitive CRP. High sensitive CRP is a moderate non-conventional risk factor according to our recommendation. And if it is high, it increases, especially it is important in low risk group and moderate risk group. It upgrades the risk group to 1 stage above. And also in patients with acute myocardial infarction, if high sensitive CRP is more than around 5 microgram, even after 4 weeks, then it is a poor indicator. That means that possibly this patient is going to have more events. So you have to treat aggressive. So high sensitive CRP is extremely important for us. Apoprotein is extremely important for us. ApoB is extremely important as rather our new recommendation says that at age 20, not only standard lipid profile is recommended, you should go with the lipid profile, which should include lipoprotein small a, ApoB. ApoA we have not recommended because ApoB is enough to help us in stratification of ASCVD. So these are our recommendations of 2020. But wait for 6 months, we'll have an update of 2023, which will be published shortly. Thank you very much for your comment.
Thank you very much, Dr. Raman Puri, for that excellent talk and finishing in time. And I would just want to know from the organizers, do we have a question answer session? Some few questions before we pass on to the next speaker, Professor Wing Commander Iyengar, or are there any questions?
I think there is a question in chat box.
Just can you read out, please? Yeah.
Is there any study regarding the
Thank you,
association
Dr.
of
Raman, for a wonderful talk. I just wanted to ask you a question and your comments on it. This HDL cholesterol, everybody, the layman thinks it's a good cholesterol. But when you do subclasses of HDL cholesterol, you have HDL C2 and C3. C3 is good, which is supposed to be about 75%, which is protected towards the heart. But C2 is a bad indicator. So how should we do this test and promote it in the public, or it'll create a furor?
Okay. Regarding HDL, we had a strong, association of HDL to coronary artery disease based upon observational study and epidemiological study. But if you look into the genetic studies, those genetic mutations which are associated with high HDL, they are not associated with reduction in coronary events. And also pharmacologically driven increase in HDL cholesterol has not shown any benefit. Rather, it has been a negative study, not a positive study. So for us, HDL, we do not consider in our risk stratification. Rather, if you ask me, frankly, I don't look at HDL level values at all. But it doesn't mean that HDL is not important. If we have to increase HDL cholesterol, it is not by alcohol, it has to be by exercise. Because increase in HDL by exercise is physiological HDL, because it is not the HDL cholesterol which matters. It's a functionality of each component of HDL which matters. And HDL is a very complex molecule. It has a lot of lipoproteins, and there are a number of these things. And even one of these lipoprotein or RNAs get dysfunctional, whole HDL becomes dysfunctional. Rather, dysfunctional HDL in patients with diabetes and CKD is more harmful to the patient rather than any benefit for it. So for us, HDL, you can just for the sake of HDL, one can do it. And if it is physiological HDL is high, is good. But remember, it is as a J shape. If it is more than 90 milligram, it is harmful. So somewhere around safer zone is around 60 to 70 milligram, is that. So therefore, we do not, in our recommendations, we do not talk much about HDL cholesterol.
I think there is one more. Any study regarding association of decreased value of LDL around 50 and dementia and memory loss?
means lowering LDL below 50 milligram with cognitive dysfunction?
Yeah, that is the question
Uh,
in the chat.
Okay, okay. I don't think, because we have been using statins for, see, the cognitive dysfunction can be because of two reasons. Either it is because of low LDL cholesterol or because of a drug. But if you look into the Fourier trial, there was a subgroup of Fourier trial that was Abingos. Is it Abingos? Yeah. In which they took only the primary endpoint was cognitive function. It was seen that there was no difference in cognitive function, means lowering of cognitive dysfunction in patients who had lower LDL versus those whose LDL cholesterol was higher. Now, forget about this. Now we have a 4-year open label study in which we have gone for about 7 years with LDL cholesterol of 28 milligram. Even that, there was no cognitive dysfunction was seen. Even in Odyssey trial, there were about 700 patients with LDL cholesterol of less than 15 milligram. There were no cognitive dysfunction. I don't think that there is any correlation between cognitive dysfunction and level of LDL cholesterol.
And yes, sir, as you had correctly mentioned, even genetically, who had a very low LDL, in fact, they almost led a normal life. Since there are no more questions, thank you very much, sir. Before I pass it on to my co-chairperson, make this as a plea that today with such eminent people, Professor Puri, Sadanand Shetty, as I can see, Wing Commander, make a plea for, along with labs, to have our own Indian risk factor calculation, which is going to be a difficult job, but somewhere we have to make a start. So thank you very much, sir. And over to my colleague, Dr. Aziz Khan.
Thank you, Vijayan. It was wonderful talk by Dr. Raman Puli, and these two are the torch bearers in the field of lipidology. Both of us has given us different guidelines, and the things have become very easy now to manage lipids with these guidelines. Previously, we had a lot of Western guidelines, and this clear cut now low risk, high risk, very high risk. Definitely has become very easy to convince physicians also. Like Dr. Raman Puri, Dr. Iyer has also given, is a legend in lipidology. He has given very short biodata. So I will just read it. He is a consultant emeritus and academic head of Department of Cardiology, Manipal Hospital, Bangalore. He has served Indian Air Force for more than 26 years. He has been head of Department of Cardiology to St. John's Medical College for 15 years. He has been life member of CSI, LI, ESC, and ES. To his credit, there are more than 68 publications. He is going to talk on very important topic where Dr. Puri has left. Should be ApoB should be primary target in the management of patient with abnormal lipid profile. Because many times what he has showed that with normal LDL also, we have residual risk of more than 20-30%. So should we target, particularly in patients who are hypertensive, who have metabolic syndrome, who are diabetic. So may I invite Dr. Iyengar to start his talk, please.
Yeah, thank you, Dr. Khan, for this kind introduction of our next speaker, Dr. S.S. Iyengar. But before moving to our next topic, we have a question here from Dr. Om sir to Dr. Raman Puri.
Offline, but maybe in the interest of others as well. So my question is, I think a very informative talk, and I'm trying to fit myself which category probably I fall in. I'll have to go back and work on it. The question is, let's say you are in a low risk category. Should one still try to reduce LDL? And if yes, should one take what are the lifestyle changes, and should one go for medication? That's question one. The question two is, let's say if you've been an alcohol for many years and you suddenly quit, do you run a risk of reducing your HDL over a period of time?
Now, coming to your first question, that for low risk group, we have a target of LDL target of less than 100 milligram. What we have recommended that in low risk group, you give 3 to 6 months for lifestyle intervention. And if you are not able to bring down LDL cholesterol, you should go for pharmacotherapy. Remember, low dose statin. You have to see. What we normally say that everybody should try to keep LDL cholesterol of about 70 milligram. Why the word 70 number? See, it's 70 number. If you have no atheroma, you will not develop atheroma. If you have an atheroma, it will neither progress nor it will regress. If you have an LDL cholesterol to cause regression, you have to bring down LDL cholesterol to below 50 milligram or to near 30 milligram. So it is better to keep LDL cholesterol around 70 milligram because that will keep in majority of patients. There is always a standard deviation. Somebody may have regression also, but you should try to keep LDL cholesterol less than 70 milligram in Indian population. So that is extremely important for us. And again, I want to say that you should not worry about pharmacotherapy. Statin is one of the safest drugs. We have been using statin since 1994 after the first S4 trial results were published. And I have never stopped in almost 35 years of my professional career, 40 years. I've never stopped statin. And I think I'm the person who never gives statin in patients, of course, with coronary artery disease, less than 40 milligram of rosa or 80 milligram of atorvastatin. And I have, despite these high doses of statin, which we normally use, I have never stopped any of my patients statin because of side effects. I have never seen cognitive dysfunction. Rather, they are more alert than what I am exactly. So forget about that if it is required. The problem which Dr. Shetty has discussed is very rightly, because it takes about 30 to 40 years for a fatty streak to mature into fibroatheroma. And it is very rare to have a 80% or 90% atheroma to cause acute myocardial infarction because they have a thick fibrous cap. It is 30-40% block which is responsible for acute myocardial infarction because their covering is too thin. And gym associated is that when you go for exercise, the pressure goes up and it just causes an erosion on the fibrous cap. And that is the reason why many people die during gym, So that's very extremely important. And the rest, of course, we can discuss in the panel discussion after Dr. Resham. Second question. Second, for whenever this question comes, that I always refer that questions to Dr. Anger.
Yeah,
Thank you,
I
Dr.
think,
Puri. Now over to Dr. Iyengar, sir.
yeah, thank you. To answer his question briefly before I go on to my talk. I mean, alcohol never goes as a prescription from your prescription file. That's one thing. But if somebody is taking alcohol, to gain to moderate alcohol. But if he has got heart failure or liver disease or stomach ulcer, of course, problem. So that answers the question. We will talk more about. Yeah. Good morning, Chairman, Brigadier Lal and his team, ladies and gentlemen. And when I landed here last night, what I saw, the mood was a bit depressive. Everything looked a bit dull. Then I realized that Delhi had lost to Rajasthan Royals yesterday. But this morning, when I walked into the hall, I could see the energy and enthusiasm team of Brigadier Lal. And my spirit also soared up when I met two of my college colleagues here. It was a great pleasure. Now I'm going to talk on apolipoprotein B, that is ApoB. Will it be a primary target for lipid profile? Now we all remember Shakespearean saying, to be or not to be. So we're going to discuss to ApoB or not ApoB. And we need to know some facts of life and of course facts of life. Before I start my talk, probably someplace I'll be treading into the territory of our clinical biochemists. So you're welcome to correct whether I go wrong. Now, this is, of course, the lipid lipoprotein separated according to the density and size. And we have, of course, the total cholesterol, which comes from HDL cholesterol, LDL cholesterol, IDL, and VLDL. Now, when you talk about LDL cholesterol, the LDL cholesterol, what we get from the reports is a cholesterol content of LDL and LPA. And non-HDL, of course, it is total cholesterol minus HDL, so it encompasses all these lipoproteins, the heterogenic lipoproteins. When we talk about ApoB, all of them have one molecule of ApoB, which contains all atherogenic particles is represented by OB. Just a word here, as we go from VLDL to IDL to the size decreases, the triglyceride content decreases, the cholesterol content increases. Also remember in each of these, whether LDL or IDL, cholesterol content can vary, not all the time same. And all these are atherogenic. And also note that all of them, is all atherogenic lipoproteins have one ApoB molecule. Now, what are apolipoproteins? They modulate the enzymatic activity of the lipoproteins, maintain the structural integrity of the lipoprotein, facilitate the uptake of lipoproteins through a receptor-mediated mechanism. Now, coming to apolipoprotein B, it is a structural protein for all non-HDL lipoproteins and modulates the centrifugal and centripetal transportation of lipoprotein with reference to intestine, peripheral tissue. Now, there are two isoforms of OB. One is OB100 that comes from liver, and it is found in VLDL, LDL, IDL, and LPA. And the one is ApoB48, which comes from the intestine, and it is a structural protein for chylomicron and chylomicron remnants. And both of them have the same gene coding. And we're also aware of the fact that when the ApoB is functional, the LDL receptor function goes off, and some gets what is called familial hypercholesterolemia mosaics. Now, under most circumstances, 80% of circulating ApoB particles are in LDL particles. And the reason for the superiority of ApoB is very simple. It is not mysterious, because trapping of ApoB particles within the arterial wall is the fundamental step which initiates atherosclerosis and it progresses. All those particles have 70 nanometers or less can get into the intimal, subintimal space and start the process of fibrosis. So it are the ApoB particles which get to the subintimal space. We're not worried about the cholesterol. The ApoB particles which carries and gets to the subintimal space. Now, a few words about LDL cholesterol. It is the measure of cholesterol mass carried by LDL particles, by far the most numerous of the ApoB containing proteins, and it is an estimate of the concentration of circulating LDL. Now, LDL cholesterol remains the centerpiece of the conventional lipid system, can be calculated by multiple equations and multiple methods, and each one can give you different results. And the commonest one, of course, followed most of the places, and even in the majority of the trials which have been quoted recently by previous speaker, they all have you Reed-Walsh formula. And you know that though it is convenient, the calculated value has several limitations. One is the methodological errors may accumulate since the formula necessitates calculation of three things: total cholesterol, triglyceride, and HDL cholesterol. Can go wrong at each one of them. And we assume a constant relationship of cholesterol and TG ratio, again, which could be different. Then even the direct LDL cholesterol measurements also have limitations, including systematic bias and inaccuracy in patients with dyslipidemias, especially those who have high triglyceride levels. Just I mentioned about the different methods and different formula for measuring LDL cholesterol. You can see here the methods were described here. This paper, they have tried 9 methods, and this paper, they described 12 methods. What is it trying to find its own identity, to find something which can reflect it accurately, and we're not found any so far. Talking about non-HDL cholesterol, it is derived from total cholesterol minus HDL cholesterol. Total cholesterol can be measured, it is said very precisely, as where our clinical biochemists have to tell us, with little bias. However, directly measured HDL cholesterol has not been validated in dyslipidemic samples and is not standardized. This could produce significant error in calculation of non-HDL cholesterol. cholesterol, particularly at low concentration of cholesterol. Moreover, non-HDL cholesterol again requires two measurements. Again, the errors can sum. Talking about ApoB, ApoB indicates the number of potentially atherogenic particles and is a better predictor of atherosclerotic cardiovascular disease. Direct measurements of ApoB are made by international standardized methods. Analysis can be performed in non-plastic state, and ApoB can be trustfully analyzed on frozen samples. For example, if you try to estimate LPA on frozen samples, it would give you wrong results, whereas ApoB, there is no problem about doing it on frozen samples. The errors of the methods are not dependent on triglyceride levels, and the methodological errors are usually low. Now, I will show some clinical studies where we have shown superiority of ApoB over the other metrics. Now, a majority of publications show that ApoB be a better predictor of atherosclerotic cardiovascular risk than LDL cholesterol. Of course, there are several instances or several papers which say ApoB and non-HDL seem to indicate similar cardiovascular risk. Now, this is one study, Swedish study, Amoris, where they looked at 175,000 individuals, 98,000 being men and 76,000 women. And if you see the myocardial infarction, the highest score is better predicted by ApoB. Next comes non-HDL cholesterol, and last LDL cholesterol. And this is the same thing. Fatal myocardial infarction is related to increasing values of ApoB. This is after correcting for age, cholesterol, and triglycerides. Now, there's a meta-analysis of 12 epidemiological studies, which included 2 lakh individuals, that concluded that ApoB has a better risk ratio of 1.43 as compared to non-HDL, which is 1.34, as compared to LDL, which is 1.25 when it comes to future fatal or non-fatal cardiovascular events. And they went on to say, the same people, over a 10-year period, if you adopt a non-HDL strategy, it would prevent 300,000 more events than LDL cholesterol-based strategy. But if you take up an ApoB strategy, that would prevent 500,000 more events than a non-HDL strategy. So you see how superior is ApoB to non-HDL and LDL. So these results further strengthen the value of ApoB clinical use. Now, this is a study for subclinical atherosclerosis, as seen by the coronary artery calcium in the middle-aged people. If the values, that is ApoB, LDL cholesterol, or non-HDL cholesterol are concordant, that is the first column and second column, even the prediction is similar. But if they are discordant, then the risk for subclinical atherosclerosis appears more strongly associated with ApoB rather than non-HDL or LDL cholesterol. This, you've seen it before, but I try to emphasize here, this is comparison between US population and Indian population. All of us keep saying Indians, by virtue, we have very low LDL cholesterol. But there, the story doesn't end. You look at this comparison between US population and Indian population. US population has higher total cholesterol, higher LDL cholesterol, higher HDL cholesterol, higher non-HDL. Whereas Indians have very low HDL cholesterol, but higher ApoB than the US population. The same here, the ApoB is 89 here and 95 amongst. So we have higher ApoB values, though women have low LDL cholesterol levels. Based on this study, whether Americans or Asian Indians are at higher risk from ApoB lipoproteins cannot be determined based on their lipid levels, because the information from lipids cannot be integrated. You've got HDL on one side, you've got triglycerides on one side, you've got the other cholesterol. ApoB, however, integrates and extends the information from triglycerides and cholesterol. So replacing the conventional lipid panel with ApoB for routine follow-ups would simultaneously simplify the clinical care and improve the clinical care. This is a study where, again, it was referred to in the previous talk, Odyssey outcome study, where about 18,000 patients who had recent acute coronary syndrome and elevated dyslipidemia or lipoproteins, despite optimized statin therapy, were included in the study, and they were followed up for 2.8 years. Now, what you see from this graph is all patients, and this is those who achieved ApoB more than 50, 30 to 50, and less than 35. So lower achieved, this is the lower achieved, this is the lirocumab group, and this is the placebo group. The lower achieved ApoB was associated with lower risk of major adverse cardiovascular events, even after coding for achieved low density lipoprotein cholesterol or non-HDL cholesterol. So even if they have achieved their LDL goals, if their ApoB was high, they were at higher risk. And with the treatment, it comes down and the event simple. So ApoB provides incremental information. So when something is providing incremental information, why not use that? Why depend on LDL or non-HDL cholesterol? This is another study where we can look at the primary prevention group as well as the secondary prevention group. In the primary prevention group, there were about 3 lakh individuals, 58% of them females. Median age was 56 years, follow-up was 11 years. If you see that again, ApoB scores over non-HDL cholesterol and triglyceride. This is for the clinically adjusted and is clinically and lipid adjusted. Same thing next, the secondary prevention group, 40,000 patients, 24% being females, median age being 63 years, and follow-up for 2.5 years. Again, if you see the ApoB scores over non-HDL cholesterol or triglyceride. Now, this is for you to tell us, these are the examples of inter-laboratory uncertainty, means the lab errors. Now, it is said that when you total cholesterol, the error is about 9%. Triglyceride is about 15%. HDL cholesterol, minus 20 to plus 36%. Measured LDL cholesterol, minus 26 to plus 32%. And ApoB is 12%. So these are the errors that include, of course, the bias as well as the imprecision. But when you're doing it in one lab, the bias doesn't come into picture, the imprecision matters. There was another entity called type 3 hyperlipoproteinemia, which I have not seen, but it is mentioned that is the forgotten, disregarded, neglected, overlooked, ignored, but highly atherogenic dyslipidopropynemia. It is as common as heterozygous familial hypercholesterolemia. It is the forgotten phenotype. And here, of course, ApoB has to be done for reaching a diagnosis. So the ApoB assay is standardized. It is important to improve manufacturers' compliance with standardization programs and specification measures. Fasting is not required to measure ApoB. With increasing use, the cost could be reduced, where you could do away with certain other parametrics. Moreover, not measuring plasma total cholesterol, triglyceride, direct LDL cholesterol, direct HDL cholesterol routinely would reduce the present cost of care. If you're following a patient, if you do only ApoB, it should be good enough. Except, of course, 2 conditions. One is LPA measurement, which you'll have to do in certain cases, though we're advocating all patients to be done at least once in a lifetime. And another one is patients with the type 3 hyperlipoproteinemia. Now, what do the guidelines and statements say? Quickly go through. The AACE guidelines say that elevated ApoB is an additional risk factor, and it may be useful to assess the success of LDL lowering therapy, and they have given their targets for high risk, very high risk, and extreme risk. 2018 ACCHA guidelines put the ApoB as one of the enhancing risk factors. FOB more than 130 milligram is an enhancing risk factor. 2019 ESCAS guidelines were a little more specific about FOB. They said that FOB can be used, could be from here. FOB can be used as an alternative to LDL cholesterol, if available, as the primary measurement. Remember, primary measurement for screening, diagnosis, and management, and may be preferred over non-HDL cholesterol in people with high triglyceride levels, diabetes, obesity, and very low LDL levels. And class of recommendation is 1, level of evidence is C. European preventive cardiology differed a little bit, where they said that FOB is promising, but not yet ready for therapeutic decision making and follow-up in practice. But what they wanted was randomized trial should be designed to evaluate outcomes of FOB-driven clinical decisions and treatment for cardiovascular prevention. Now, Lipid Association of India, elevated FOB is a moderate non-conventional risk factor. A level of more than 110 milligram per deciliter of FOB corresponds to an LDL cholesterol of more than 130 milligram. To assess ASCVD risk, it's preferable to estimate FOB in patients with diabetes, metabolic syndrome, obesity, high triglyceride concentrations, and those who have achieved very low LDL cholesterol levels. And although it should be done in all those patients who have achieved their LDL goals. For example, this morning, we're just talking about one patient who has reached an LDL goal of 1 milligram per deciliter. It's amazing, astonishing. But in this patient, we should do FOB in C. So effort should be made, doing LDL cholesterol has been entrenched into our medical practice. It is very difficult to get away from that. So we should make efforts to bring in gradual change in perception of and the importance of FOB amongst physicians, patients, and labs. It would take time and efforts to introduce FOB estimation to be included in the standard lipid panel, initial and follow-up. Now, these are the targets recommended by Lipid Association of India. FOB goals for extreme risk is less than 50 and high risk is less than 80. Now, in concluding remarks, just I would like to say, first conclusion, it is not that LDL cholesterol or non-HDL cholesterol are wrong. They are merely less precise than FOB, and precision matters in clinical practice. FOB is superior to LDL cholesterol and non-HDL cholesterol as a marker of cardiovascular risk, and also for the adequacy of lipid loading therapy. Now, superior laboratory performance is on its own an unanswerable argument for the widespread clinical introduction of FOB. And this was by Silverman, I think, who said apolipoprotein B unifies, amplifies, and simplifies the information from the conventional lipid markers as to the atherogenic risk attributable to the FOB lipoproteins. The use of LDL cholesterol to assess cardiovascular risk and guide therapy is firmly established and entrenched in the minds of clinicians and routine practice. Replacing LDL cholesterol with FOB is likely to take time. Effort should be made to change perceptions and practice gradually, a pedagogical issue. Progress is impossible without change, and those who cannot change, their minds cannot change anything. And LAI is here to change this practice. Thank you. Are there any questions from the audience, or you want to close?
Thank you, Dr. Iyengar, for your excellent talk on very important topic, highlighting the importance of FOB in day-to-day practice. Do you suggest that while screening patients for health checkup, etc., in a diabetic patient, obese, should we go for lipid profile or just do FOB?
Yeah, once we start the practice of using FOB routinely, I think follow-up with only FOB will be enough. As I mentioned, except in patients who have LPA, you'll have to do LP. Otherwise, a follow-up of the patients. But as mentioned by the European, one of those European associations, we need to have FOB targeted clinical trials, and we should have, I should identify the targets, and we should also assess the risk benefit advantage of this particular procedure, then probably it will come into practice routinely. But as on now, what we should advise, the LDL and non-HDL cholesterol continue to be our primary and co-primary targets. And those who have achieved these goals do FOB.
Any other question in the chat box?
Anything with chat box? Yeah. If there is persistent high CPK value, what would be the judgment on giving statin for benefit of patients? High CPK value, if you think patient has got it because of statin, means he has got myalgia and his CPK values are more than 5 times higher, then you need to withdraw statin. Then you should, giving a break of 2 weeks, you should restart him on a low dose statin or a different statin. And if he's tolerating it, you can continue statin. If it doesn't tolerate that also, you could even reduce these statins to a low dose, alternate or weekly dosage. If that doesn't work out, then you have to stop statin. And now we have other drugs like bempedoic acid to be tried, or along with ezetimibe. So statin, you should be firm before stopping the drug that it is due to statin and he has statin intolerance. If you are convinced he has statin intolerance, stop it. And you have other drugs available like ezetimibe and bempedoic acid.
Your LDL level normal, your LDL non-HDL cholesterol normal, and FOB is marginally raised. In that case, we'll suggest to have the aggressive management of lipids, or
Please come again.
see if your LDL is say 50-55, non-HDL cholesterol around 100, but FOB is raised. So how do you manage these patients?
No, firstly, have you achieved the LDL goal? Because the LDL goal, it has to be high risk, very high risk is 50, extreme risk is 30.
Yeah.
So if you reach the LDL goal, of course, and if you achieve the LDL target, then you should do FOB. And if OB is high, you have to be a little more aggressive in your lipid lowering therapy.
Okay.
There's one question, any structural changes of FOB in oxidative stress? I'm not very sure about it. But FOB has been implicated in patients. They say it might predict metabolic syndrome if somebody's FOB is high, the recent paper. And FOB is high and there is a discordance between LDL and FOB. They also say it might predict CKD. So they're the two new thoughts. But I don't know about this oxidative stress. Anybody knows about it?
Should we do it at a very young age, 20 years or so, or FOB?
Yeah, LAI advises routine screening at the age of 18 or 20 or at the time of college entry. And somewhere we should start doing FOB and LPA at this stage.
Okay. Another question. Do we have any Indian
Asian guidelines in lipid profile and glycemic status, age-wise and gender-wise? There are guidelines, of course. We have got a diabetic dyslipidemia, the lipid consensus. We don't call it guidelines because we don't have our own data in large measure to come out with guidelines. We have come out with consensus statement for treating diabetic dyslipidemia. And there's not much of difference as far as the gender is concerned. Age-wise, of course, the adults is concerned, there's not much of difference. You follow the same recommendations. Anything else you want to add, Rama?
So I think should we conclude this session here?
Any question from the in-house audience for Dr. Iyengar? Yeah, there's a question from Dr. Gupta, sir.
Will there be any use of doing FOB without LDLC? Because will there be any use of doing FOB without LDLC? The logic is, on a molecular basis, if you see each particle has got one FOB molecule. Within the particle, the cholesterol content can vary.
Yes.
So by logic, cholesterol concentration should be more relevant than the FOB.
No.
So increase in FOB means what? More numbers of LDL particles?
FOB is
What does it mean? Increase in FOB means what?
when you're doing FOB, you're doing all the atherogenic lipids. It is the particles which you are calculating or estimating. Whereas the LDL, when you're doing, it is the mass of cholesterol. What is important is the cholesterol content can vary. It can be low or high in each of them. But when you measure, it is FOB is constant because each one has got one molecule. And it is the FOB particles which penetrates the endothelium and enters the subintimal space. And that is important. And it is not only the cholesterol which is inside the molecule is important, also the FOB itself, plus the oxidized phospholipids in that. All of them initiate the atherosclerotic process. So we can do away with doing LDL cholesterol if you do follow FOB. FOB, LDL, as I showed you, it tells you only the LDL cholesterol in LDL plus lipoprotein little a. It does not tell you the other cholesterol.
And we
So-
are taking into account only FOB 100 or FOB 48 also.
When you measure FOB, it mostly indicates FOB 100, but very small contribution from FOB 48 in the estimation.
So if the liver is producing more cholesterol, it will produce more FOB also to make more LDL, VLDL particles.
See, whatever it may be, each particle has, whether it's LDL or VLDL or IDL, so they have one ApoB. What Dr. Iyengar has said is that the particle cholesterol content may vary. It is an ApoB particle which gets into the subintimal space, initiate process of atherosclerosis. So there are greater chances of having atherosclerosis when you have high ApoB. Cholesterol, of course, is important, but ApoB is more important. It's a particle which gets into the subintimal space. And remember, 10 years from now, what we are discussing today, it will be a reverse swing. It will be ApoB, which will be considered in almost all patients. It will be an important investigation.
To say the same thing, in LDL cholesterol now is almost 80% of it's represented in FOB. So other 20% it will not represent. If you do FOB, you get 100%.
Thank you.
Can I ask one question, Iyengar?
Yes, Dr. Shetty.
Yeah, only thing, as Dr. Aziz asked, our LDL primary target, non-HDL secondary target, if it is achieved, now if the FOB is high, what extra we can do, therapy-wise? This, something like, when we do the diabetic, A1C, normally, on the higher side, but the sugar otherwise is fine, fasting PP and all. So what additional therapy for reaching primary target fine, quote primary target is fine, and then FOB is high. What additional therapy?
Dr. Sadan, once you establish the goal for FOB,
Yeah.
so you
No,
achieve
the-
that FOB goal with lipid lowering therapy, same statins, ezetimibe, bempedoic acid, PCSK9, inclisiran, same. The atherogenic lipid you have to reduce. You have a target. Earlier we used to have total cholesterol. We have come to LDL cholesterol. We have come to non-HDL cholesterol. Now we are going to OB.
No, I agree. Suppose the LDL is we reach 50, non-HDL 80. Now the FOB say 90 or 100.
Now you tell me what is your FOB goal?
Yeah, FOB around 80 you are saying there, or what is the goal there?
Yeah, we have
70
to
to
go
80. I think probably 70 to 80. But suppose if the FOB is 100, what addition we can do?
The extreme risk is less than 50 FOB
Yeah.
goal.
Yeah.
Okay. So you have to achieve that. So you intensify your lipid lowering therapy.
Okay.
Whether it is statin, ezetimibe, bempedoic acid, PCSK9, glucagon.
That situation you have to only therapy. So you intensify, don't look at LDL cholesterol. That is not important for us, especially in patients with who are very high risk group and extreme risk group. So just bring down by adding, if you have to intensify statin. If you require another additional, even if you try to achieve ApoB, LDL comes down to 20 milligram or 15 milligram, that should not be a matter of concern at all, because you have to achieve ApoB target.
See, we are not used to this because now, for example, when you reach LDL goal, if non-HDL is high, what do?
Yeah.
We intensify the therapy. Same thing. You achieved the goal, but ApoB is high, you intensify the lipid lowering therapy. So we have to have clear-cut targets and achieve that.
Okay.
Thank you, Dr. Inger, for your excellent talk.
Thank you.
And then I think we'll declare that this session is over and ask Lal Patlab and other organizers to take over further proceedings.
Yeah. Thank you, Dr. Iyengar, sir, for this wonderful talk on various utilities of ApoB as an emerging marker. So I would now like to request Dr. Raman Puri, sir, to come onto the stage and for a small token of appreciation from our side. And I'll request Dr. Arvind Lal, sir, to hand over the memento to Dr. Raman Puri, sir. Now I would like to request Dr. Iyengar, sir, to come onto the stage, and Dr. Om Manchanda, sir, to do the honors for us. To hand over a small token of appreciation to Dr. Iyengar. Thank you once again, Dr. Vijan and Dr. Khan, for moderating the first two sessions of our CME. Sir, your trophies will be sent across to you. And I would also like to take the opportunity to thank more than 100 participants who are with us on online platform for the first two sessions of the CME, and we're expecting even more participants for the rest of the CME. So now I'll request you all to take a tea break. We'll join again in 30 minutes for rest of the sessions. Okay, as sir said, the tea break has been like short to 15 minutes. हाँ, अभी डिस्प्ले ऑन मत करो। May I have your kind attention? Requesting you all to come and take your seats for the next sessions. So for the next 3 sessions, I'll be requesting Dr. S.K. Gupta, sir, to join us here on stage as moderator. Please request sir to moderate the sessions. I will take the opportunity to introduce Dr. S.K. Gupta, sir, who has more than 40 years of He has more than 40 years of experience in teaching biochemistry to MBBS, BDS, and MD students, and has also the experience of guiding around 17 medical students from the field of biochemistry and related specialties. He is a fellow of Association of Medical Biochemists in India, national body, and he's delivered orations, guest lectures at various conferences and CMEs. He has published many research papers in various national and international journals, and is also an author of more than 15 books. I welcome you, sir, to moderate the rest of our scientific sessions. So our next moderator for today's sessions are Dr. Seema Garg, which is a professor, Department of Biochemistry, University College of Medical Sciences and GDP Hospital, Delhi. She is an academician and researcher with more than 20 years of experience. She believes in value-based education and ethical practices in research. She was instrumental in setting up the Department of Biochemistry in newly established AIIMS Nagpur, where she worked as head of the department and was managing COVID ward during pandemic. She has more than 35 publications in national and international journals of repute and many chapters in different books and courses. So I request Dr. S.K. Gupta, sir, to introduce our next speaker. Our next speaker for today's scientific session is Dr. Anuj Prakash. Dr. Anuj, sir, please join us.
So I welcome Dr. Anuj Prakash. He is HOD Biochemistry at Medanta Hospital. He's changed it. He has been, his research interests are in the area of oncology, diabetes, COVID-19, quality control, and QMS. He has published many research papers in top line journals. He has received numerous awards and honors for the contribution in the space of digital health adoption in healthcare industry. He has supervised XLRI mentorship programs and mentored many students in the industry. He is a member of several professional bodies, including ACBI, AMBI, ECBI, and has experience with NABL, NABH, and CAP advisor. I have known personally Dr. Prakash for a very long time, since his postgraduate days in PGIMS Rohtak. He's been very promising and very coming. So I wish him all the best. Welcome, Dr. Anuj Prakash, for your lecture.
Thank you, sir. Thank you, sir, for the nice introduction. I'm delighted to be here in this distinguished audience. First of all, I'd like to thank I think Lal Path Lab team. Dr. Arvind Lal is here, Dr. Manchanda, Madam Lal, and Lipid Association of India for giving me this opportunity to speak on a topic of interest, I think, which is very important in the context of in the morning we have heard Dr. Lal about speaking about the incidence of cardiac diseases increasing in the country, and how it can be prevented with the help of preventive tests, in which lipid profile plays a very important role. In the morning, we have heard from our previous speakers the importance of ApoB, LDL. Now the question is, how do we give this accessibility of lipid profile to general population? Now the basic issue, which my topic is basically a lot of from the point of very evidence-driven versus belief-driven concept. During our practices, we know we get a lot of calls from our OPDs, from our sample collection centers, where our phlebotomist calls us, say, sir, this person has come with tea, with coffee, with biscuits. Shall we take his sample or not? And many of times we refuse the patient to collect his sample since he's not fasting. This has caused a lot of issues, and this is the topic which I want to touch upon today, because I believe there is a merit in doing lipid profile on fasting basis. And I have tried to put some evidences behind this concept, which I'll share with you in presentation with today's presentation. We know the lipid profile and its importance in assessing the cardiovascular health. That this topic has already been discussed, has already been, all the merits of lipid profile has been discussed today morning. Just to a summary, or just sort of customary, I just speak that what is lipid profile for for everybody who is present here. It captures basically 4 tests. Traditional lipid profile, which total cholesterol is one among them, which measures total amount of cholesterol in blood, including the HDL and LDL cholesterol. HDL cholesterol, which we measure, it's called high density lipoprotein cholesterol, which is often referred to as good cholesterol. LDL cholesterol measures the level of low density lipoprotein, which is often called a bad cholesterol, because it can build up into the walls of arteries, leading to atherosclerosis and increased risk of heart disease. And the last, triglycerides, which is something which I think nobody has spoken about today morning. So I assume that this is one marker, which is actually another type of fat that can contribute to the buildup of plaque in the arteries. Now, what are the limitations of traditional fasting? So I would call it a traditional lipid profile, and I would say a newer non-fasting lipid profile. So traditional lipid profile, which is a fasting profile, it has few limitations. The first limitation, of course, is timing. The traditional lipid profile warrants a person to be at least fast for 10 to 12 hours, which is a common practice, which is a common convention, which everybody says, sir, khali pet aana hai, fasting mein aana hai. This can be inconvenient and may not be practical for many patients. It gives a limited information because the traditional fasting lipid profile does not provide information on another risk factors for heart disease, such as inflammation or insulin resistance. There is a lack of specificity. While LDL cholesterol is commonly referred to as the bad cholesterol, not all LDL particles are created equal. Some are small and dense and have been shown to be more strongly associated with cardiovascular risk than larger particles. The traditional fasting lipid profile does not distinguish between different types of LDL particles. There is a lot of variability. Lipid levels can vary from day to day, a single measurement may not accurately reflect a person's true lipid status. And many other factors like medications, medical conditions, etc., diet can also affect the lipid profile. So now, what is a non-fasting lipid profile? The basic definition of non-fasting profile is simple. It is basically a similar set of conditions without 10 to 12 hour of fasting. If you see in this picture here, the fasting says approximately midnight or after 8 p.m., we get our next sample morning 8. So approximately more than 8 to 10 to 12 hours of fasting. However, the non-fasting is less than 8 hours since your last meal. So this is the basic difference between these two sets. Otherwise, both are same. Now we have comparison with the fasting lipid profile. Now, what is the basic difference between these two is, we can see here in this figure, the plasma contains remnant lipoproteins of hepatic origin in the fasting state. Whereas once you take your meals, the remnant lipoproteins of intestinal origin also additionally adds into your blood profile. So that's the basically difference between two. The fasting only has hepatic origin lipoproteins, whereas after feeding you have lipoproteins from your intestinal also. Now, this concept of non-fasting is not new actually. In fact, a lot of countries have started adopting non-fasting concept from almost 2009. In fact, before 2009, essentially all societies, guidelines, and statements either required fasting before lipid profile measurements or did not mention this requirement at all. However, this was changed in 2009 when a country called Denmark, its Danish Society for Clinical Biochemistry has introduced a non-fasting concept. I'll explain in detail. Just to enumerate how this journey has progressed. In 2011, the United States American Heart Association has started this acceptance of non-fasting. Then 2014, UK, NICE, National Institute for Health and Care Excellence, has introduced this non-fasting state. Then European countries have your European Atherosclerotic Society and European Federation of Clinical Chemistry and Lab Medicine has introduced this concept in 2016. Canada has adopted the same guideline in the same year. Then European concept, again, European Society of Cardiology and European Atherosclerotic Society has introduced in 2016. Brazil has got in same year. And 2017, next, rest all American Association of Clinical Endocrinologists have adopted this or endorsed the non-fasting state. So what I was telling you about Canada, based on the Copenhagen General Population and City Heart Studies, the non-fasting lipid profile testing has been adopted in Denmark since 2009. In Canada, the reporting of non-fasting, including LDL, and was adopted in Alberta in 2014. In 2016, Canadian Cardiovascular Society Lipid Guideline Panel recommended the use of non-fasting state, so on and so forth. Now, to corroborate or to confirm these findings, obviously there is studies which were done well behind these guidelines. Journal of American Medical Association found that non-fasting lipid profile were just as accurate in predicting the risk of heart disease as fasting lipid profiles. The major study came from Denmark, where they've studied this data on almost 8 lakh people, which is practically probably the whole Denmark was covered. The study analyzed data from over 8 lakh individuals in that country and found that non-fasting profile were more accurate predictors of heart disease risk versus fasting lipid profiles. Then Journal of Clinical Lipidology has done the similar study on almost 45,000 individuals. Then a systematic review and meta-analysis published in Canadian Medical Association in a journal in 2018 concluded that non-fasting profile was reliable and convenient alternative to fasting. A study published from Journal of Clinical Endocrinology and Metabolism in 2017 found that non-fasting profile was a better predictor of insulin resistance compared to fasting profile. And similarly, a later study published in Annals of Clinical Biochemistry found that non-fasting profile was associated with higher prevalence of metabolic syndrome compared to fasting profiles. Now, I thought, why not do a similar study in my hospital? So I did a similar study where I did a small pilot study in Vedanta Hospital. I took almost 50 patients where I took split samples of same patient, fasting versus non-fasting. And this is the data which we have got. If you see in this data, out of cholesterol, HDL cholesterol and LDL cholesterol, there was hardly any difference. But the p-value was not significant. However, which means these values were not different. The mean of cholesterol was 159 versus non-fasting was 156. HDL cholesterol fasting was 48, non-fasting was 48.4, LDL was 85.7, and non-fasting was 89.3. So approximately there was no difference at all between these three parameters in fasting versus non-fasting. However, we all know what gets affected was triglycerides. And it was similarly seen in this finding also. The fasting level was 142 versus non-fasting was 159. And it was a significant change as per the p-value. And VLDL cholesterol is obviously a calculated parameter of triglyceride. It's Tg/5. So the change was similarly seen in VLDL cholesterol. Now you can see there's a difference between triglycerides and VLDL cholesterol. But now I'll come to a next point. I'll come to this point later on. But just wanted to prove one particular concept of evidence-driven versus belief-driven. Non-fasting profiles and fasting profiles, fasting lipid profiles are mainly driven by belief. If, for example, we have always done it that way, that's what all phlebotomy says. कि हम तो ऐसा ही करते हैं. Old guidelines, which were never changed, never questioned, highly impractical. Risk of hypoglycemia is more in fasting profiles. Cost is increasing because the patient has to come again after 2 hours. Unnecessary visits of a patient, which sometimes divert them actually. Sometimes they may not come back. It diverts time, energy, and resources from patient care. On the other hand, as I said, so non-fasting is an evidence-driven system. Almost 3 lakh patients or persons were tested on. These are the new guidelines, which are very practical to use, very safe. Cost is saved. Same visit, patient can give a sample, time efficient and patient friendly, lab friendly, and physician friendly. In fact, we got a lot of this request from our clinician itself. They say, sir, please do not reject the patients, just take the sample. You mentioned on the sample that it is a non-fasting sample, but please take the sample. And we are impressing this idea to all our collection centers, labs, OPDs, that please do not reject any patient or do not return a patient who is non-fasting. Just take the sample, mention non-fasting. Now, what are the factors which can affect non-fasting lipid profile? The factors that can affect non-fasting lipid profile results are, or do we have any factors that can affect non-fasting lipid profiles? Non-fasting lipid profile does not affect risk stratification using the Framingham risk score, which uses total and HDL cholesterol and has been shown not altered substantially by eating. Non-fasting lipid testing may also remove entirely the need for patients to fast for routine blood work. And also there is no impact of food intake, exercise, and medication on non-fasting profile. What are the clinical implications? Do we have any clinical implications if we go for non-fasting profiles? Implication for the patient. A random non-fasting lipid profile is practically compared with a fasting profile because it does not interfere with the patient's normal life. And it allows going to the laboratory for the blood draw at any time of the day. Non-fasting samples are safe, whereas fasting for some patients with diabetes, especially on anti-diabetic medications, may lead to a risk of hypoglycemia. Non-fasting profiles will be time-saving and cost-saving for patients because the need to return to another day for a fasting is eliminated. This is a study which is done in Copenhagen study, which I was just mentioning. It also shows that the mean maximal increase of triglycerides of 26 milligram was there, and in remnant cholesterol is of 8 milligram compared with fasting levels, which occurs 3 to 4 hours after the last meal. So if you can see, this finding is almost similar to the findings which we have got in our lab on 50 samples. This is another study, which again done in Copenhagen, which says that the mean maximal change in lipids, lipoproteins, and apolipoproteins in random non-fasting compared with fasting was hardly any change, which is clinically insignificant. There were actually, if you see the time since last meal, there is a slight bulge on 3 to 4 hours, but otherwise it is clinically insignificant. Same another graph which says that the triglyceride was increased by 16.95 mean. Other than all other parameters were almost on the lower range. In fact, cholesterol was rather decreased in non-fasting samples. So what are the implications for prognostic and diagnostic options? So under non-standardized, random, non-fasting conditions, plasma triglycerides on average only increase by 26 milligram or at 4 hours after a habitual meal. So this figure of 26 milligram was seen by us also, and by the Copenhagen study also has the same 26 milligram. Now, does this have any clinical significance? So such minor changes are clinically unimportant because a clinician is only interested to know whether plasma triglycerides are 176 milligram versus say 440 milligrams. Whereas difference between 176 and 202 is clinically insignificant. Now, the implications of risk stratification. So does this have any risk stratification implications? Again, studies have shown that non-fasting lipid levels predict risk for coronary heart disease and stroke better than fasting lipid levels. It is perhaps due to the added atherogenic effect of cholesterol in remnant lipoproteins, including intermediate dense lipoproteins and chylomicron remnants, which cross the vascular endothelium like LDL and become trapped in the artery wall, contributing to plaque formation. So basically what they are trying to say is that when you eliminate what you're doing actually fasting, you are actually making it unnatural condition. Rather, they're saying that when you are non-fasting, that is your natural condition. So remnant cholesterol is captured along with LDL cholesterol in the non-HDL cholesterol level, regardless of the time since eating. A 2012 meta-analysis also found that non-HDL cholesterol is a better predictor of cardiovascular disease than HDL cholesterol. Therefore, non-HDL has been recommended as an alternate target to LDL cholesterol. So what we are saying here is LDL and non-HDL are those two markers, which is rather important that we've seen in the previous discussions also. So triglyceride was never surfaced in any of our previous discussion, basically, and which gets affected actually. So there is no point in having a fasting levels when we are actually finding no difference of non-HDL or LDL in non-fasting versus fasting. Now, is there any implications for therapeutic options? Now, because statin therapy is decided on the basis of an individual's global cardiovascular risk, familial hypercholesterolemia, and diabetes, and not just on plasma lipid levels, minor changes in the lipid profile from fasting to non-fasting conditions will only affect a few individuals regarding the decision to start a statin or not. In fact, many guidelines use total and HDL cholesterol for risk stratifications. Many guidelines use LDL cholesterol for risk stratification. Many are using ApoA guidelines for risk stratification. And these measurements are practically eliminated the effect of triglycerides, which gets actually affected. And that too, we have seen a very minimal. Similarly, as I just said, many guidelines use LDL cholesterol to monitor pharmaceutical treatment and as goals of treatment. Now, implications for clinical trials. Non-fasting lipid profiles will help recruit and retain patients in lipid-lowering trials and will reduce trial costs. In fact, this is the concept here. Now, we want to test our lipid-lowering drugs on non-fasting subjects. This is because ethics committee in many countries do not allow patients to be asked to fast before the first study visit, which means an extra study visit simply for the lipid profile. The use of non-fasting lipid profiles during follow-up visits will be more practical for study participants. And finally, because non-fasting lipid profile measurements are used more and more commonly in clinical practice, it is equally important that future lipid-lowering trials are conducted under non-fasting conditions to match the clinical reality of the future. Now, what are the potential benefits of non-fasting lipid profile? As I said, it is more convenient for the patients. They do not have to fast for several hours and timelines of screening and follow-up testing. Very cost-effective, often less expensive than fasting lipid profiles. More accurate reflection of real-world lipid levels. A non-fasting lipid profile can provide a more accurate picture of a patient lipid profile under normal real-world situations rather than artificially created situation because of fasting. No impact on cardiovascular risk prediction. Studies have shown that non-fasting profiles provide similar results. Fasting profiles, it does not affect risk stratification using the Framingham risk score, which uses total and HDL cholesterol, and reduce risk of hypoglycemia, especially in diabetic patients on anti-diabetic medications. Now, this is a summary of international guidelines for non-fasting recommendations. Canadian Society says non-fasting is recommended. However, fasting lipid is required if individual with known triglyceride levels are more than 398 milligram per deciliter. American College of Cardiology and American Heart Association Task Force says non-fasting lipid profiles or fasting lipid profiles for adults not on lipid lowering drug therapies. If non-fasting plasma triglyceride is more than 398, repeat in fasting state. Adults with a family history of premature atherosclerotic cardiovascular diseases or genetic hyperlipidemia should have a fasting lipids. European Society, Atherosclerosis Society and European Federation of Clinical Chemistry says that non-fasting is recommended. However, if non-fasting triglycerides are more than 442, repeat in fasting state. And National Clinical Guideline Centers or Joint British Guideline says non-fasting is recommended. If non-fasting plasma triglyceride is more than 885, repeat in fasting state. And adults suspected of familial hypercholesterolemia can have a subsequent fasting sample. So I'm not saying that we can get away with the fasting samples. However, fasting is needed only a very few subset of population. That is, in selected patients prior to starting therapy that may itself result in or modify significant hypertriglyceridemia, or patients with genetic lipid disorders, for example, familial hypertriglyceridemia, can only have fasting requirement. Otherwise, normally you can get away with the fasting state. A take-home message is, while it may take some more time for universal acceptance of non-fasting screening, the benefits afforded by non-fasting states such as improved triglyceride-related risk identification, avoidance of evoked hypoglycemia in patients with diabetes, more streamlined healthcare delivery will eventually pave the path for its adoption. In conclusion, non-fasting lipid profile is evidence-driven versus fasting is absolutely belief-driven. Total cholesterol and natural cholesterol do not vary at all in non-fasting state. LDL cholesterol and triglycerides might vary, but very slightly, which may not affect clinically or otherwise. Just to touch upon, I thought just to add 2 more slides on, do we see the world like this in future? So there is a future directions are going in this direction is that probably in coming years, NMR lipoprofile to analyze the lipoprotein particles in the blood will come. It provides more detailed information of the size, number, and distribution of various lipoprotein particles. Oxidized LDL has been implicated in the development of atherosclerosis. Newer drug targets for lipid disorders such as PCSK9 inhibitors and RNA-based therapies are coming up. Integration with other health matrices like, as you know, lipid profile is just one of the many health matrices that can be used to assess cardiovascular risk. In the future, it is likely that lipid profiling will be integrated with many other health matrices such as blood pressures, inflammation markers, and genetic factors to give a holistic picture of a patient. So this is my view on this topic. Thank you.
Any questions, please?
It's not a question actually. Rather, it's some thought which is coming in my mind, which I would like to share with this August gathering. First of all, I would like to thank Dr. Anuj for giving such beautiful presentation on fasting versus non-fasting lipid profile. As Dr. Anuj has said, and it's documented also, the tag level is going to change in non-fasting state, and that's he said it's like non-nominal. 26 milligram per deciliter is the value you said will be varying in the non-fasting sample. So I just have little input into this. When we are telling non-fasting sample, we are not stratifying that how many hours after taking meal we are going to take sample in a non-fasting condition. All these studies which you have enumerated, they have not specified that after 2 hours of taking meal, they have taken the sample, or it is after 4 hours they have taken the sample. It is a sort of random sample which they have taken postprandially. So there is a catch. If we see the chemical aspect of the lipid profile, lipoprotein metabolism, we totally understand, all of you will agree with this, that chylomicron, which is dietary component, dietary thing, which is going to carry the exogenous triacylglycerol in the plasma, is going to be there in the circulation for maximum 2 hours. After that, it's going to get metabolized. It becomes remnant and gets cleared off. So that in that 2 hours after taking the meal, that triacylglycerol, exogenous triacylglycerol, is going to give the hampered results of triacylglycerol, which versus fasting sample. And when we talk about the VLDL, it comes to the circulation after taking meal approximately at around 4 hours. So what I just, it was a spark in my mind that this window period of 2 to 4 hours is an ideal time after taking a meal, where we can ask the patient to give the sample. And that period, we will not have any interference either by exogenous triacylglycerol or by endogenous triacylglycerol, which the liver is producing after excessive carbohydrate meal. So this window period of 2 to 4 hours after taking meal is a safe period as far as my understanding of lipoprotein profile is there, and that will not interfere with the triacylglycerol assessment. It will not give falsely elevated values of triacylglycerol. So I just want your opinion in this.
No, you are right, actually. If you see this particular slide here, what they have done is they have done sampling at every hour.
So,
And in fact, on the fourth hour, that's the maximum, and then it started decreasing. So I think probably 3 to 4 hours of the meal is probably the right time,
Yes.
because that's a maximum bunch here.
Yes. So exogenous tag also will not be interfering, and endogenous tag also will not be interfering. So that we can think of. We can plan some projects and can do certain studies at a large number of samples, where we can see whether this window period is safe to do the lipid profile or not.
I think
Because
that
randomly taking the sample after taking the meal is certainly going to vary, because the population in Haryana, they consume lot of fatty meal. They take a lot of milk and ghee. So their diet will have different content of lipid, and that will give the various variable results in lipid profile postprandial. So
that's
Dr.
right.
Anuj,
Yes, sir.
you have any idea about this change in the triglyceride? Because most of your study patients are in the hospital setup. So is there any idea about those with diabetes, without diabetes? Because triglyceride could be the differentiating factor.
Right. No, sir. I could not, differentiate the patient on the diabetes versus non-diabetes status. We just had, these are our executive health checkup patient, basically, which come for our regular tests. I'm assuming they were non-diabetics. So
No, that assumption is not, because
Right.
diabetes is a very big issue.
Right.
So anyway, that is good one. Anything else, or can we move to the next?
That's a very good presentation, Dr. Anuj. First of all, I would like to congratulate you on this presentation. And personally, I'm also an avid believer of that fasting sample is not required, because there are two factors actually in this. When we talk about the risk stratification, specifically when we talk about NCEP criteria, they are not taking into consideration the levels of TG. And so many research articles are there which are saying that the role of triglycerides in atherosclerosis and heart diseases is controversial. Nobody has been able to establish it. So one thing. So rather than concentrating only on the TG levels, we should be thinking more about the HDL and LDL, as you had said that it's not going to be affecting. And another thing is that non-fasting levels it's easier to catch the people in insulin resistance, because once the insulin resistance sets in, it's more important that what happens to the exogenous triglycerides, what is happening to that. Once the insulin resistance sets in, sir, I think you'll agree with me that the clearing of TGs, that is hampered. So if we are getting more TG levels in the non-fasting state, it is easy. That's why I think the studies are saying that is correlating more with the patients insulin resistance and metabolic syndrome. So I personally feel taking a non-fasting sample easier to do, as well as we'll be able to catch more people with metabolic syndromes. Another thing which I would like to say is, yes, the diabetes plays a very important role. my personal experience, I had taken the patients of diabetes with hypertriglyceridemia and without hypertriglyceridemia. And it was pretty difficult to find the people with diabetes with hypertriglyceridemia. So I don't think there is a very great correlation of triglyceride levels. Although classically we have been studying that in diabetes, type 2 diabetes, hypertriglyceridemia is very common. My personal experience, it is not that common, at least not in the Indian scenario, not in the North Indian population. So I think for our population, doing a non-fasting sample, easier to do for the patient, and it will give like whatever is the purpose of doing it will pretty well solve it. So thank you, and Dr. Anuj.
Yes, sir.
It's a good lecture, great lecture. The sir was raising an issue about diabetes. When you have an uncontrolled diabetes complicating type 1 diabetic persons, they have hypertriglyceridemia. Once when the levels of sugar brought down to control levels or euglycemic state, you don't get an increase in the triglyceride, becomes normal. Whereas in type 2 diabetes, always it is preceded by insulin resistance, features of metabolic syndrome plus or minus, they have hypertriglyceridemia. And the same thing continues when the sugar comes down, the triglyceride level do not come as it is happening in type 1 diabetes. It is always raised. Most of the people will have this atherogenic dyslipidemia for a lifelong period. It is very difficult to control hypertriglyceridemia in people with type 2 diabetes, in spite of the fact you have umpteen number of drugs to be used for control of hyperglycemia. So hypertriglyceridemia is being seen commonly with type 2 diabetes. All that we should do is to take only the non-fasting sample and not the fasting one. Fasting sample is required only for people in whom you have already diagnosed familial hypertriglyceridemia, or those people who are taking treatment for familial hypertriglyceridemia with repeated attacks of pancreatitis. You need to probably request them to come for a fasting sample. Other than these two things, I don't think we require any fasting sample. Even people with diabetes, they are now switching over to HbA1c, from HbA1c, the ambulatory blood sugar monitoring techniques. I think these are all the things which are now on the pipeline, and many things are now in the pipeline. Probably that will improve the hyperglycemic control. I don't think fasting sample is no longer required.
Thank you. Thank you, Dr. Anuj.
Okay, sir.
Thank you very much for a very good lecture.
So now I'd like to call Dr. Vanna Lal ma'am. Please come to the stage and hand over the small token of appreciation from our side to Dr. Anuj. So please. So due to time constraints, we have decided to straight away move to our next section of panel discussion. Okay, sorry for the mistake. And I would like to welcome Dr. Kamal Modi to stage, our next speaker, and I'll request our moderators to introduce Dr. Kamal Modi. Switch.
It's my pleasure to introduce Dr. Kamal Modi. He's a graduate from Surat Municipal Institute of Medical Education and Research in Surat, and he did his MD Biochemistry in 2015 from Government Medical College, Surat. Currently, he's working in Dr. Path Lab as a senior consultant biochemist since 2018, and he's a trained internal auditor and conformity assessment. He's also specializing in that, and generally, he's a well experienced in reporting all the routine chemistries and specialized assays. His research interests are in diabetes, dyslipidemia, reproductive health, and biochemical genetics. I welcome you, Dr. Kamal, and can start your lecture, please.
Yeah. So thank you, ma'am, for the nice introduction, and good afternoon all. So here we are discussing about the ACVD risk, and as earlier said and briefly introduced by the Dr. Raman Puri sir regarding ACVD risk and what is the need of that risk stratification, because not the treatment is not the same for all kind of patients. As far as clinical history and lipid profile results, the risk stratification is required, and according to that, treatment goal has to be decided. So, first of all, what is ASCVD risk score? ASCVD risk score is a probability of having a cardiovascular problem such as heart attack or stroke in next 10 years, and why it is required. As earlier said, that Indians are at very high risk of developing ASCVD, usually get the disease at an early age, have more severe form of disease, and have poorer outcome as compared to Western population. Also, many individuals remain asymptomatic before they get heart attack, and ACVD risk helps to identify high risk individual even when there is no symptoms related to heart disease. And also, this ACVD risk category helps clinician to decide when to consider therapy and what should be the treatment goal. Let me understand by the example. Like this patient, 55-year male, having history of hypertension, and his lipid profile are as follows, where you can see LDL direct is having 140 milligram per deciliter. Apart from that, uh, HDL is normal one. So as far as these results concerned, first thing is in the mind that do we start the statin treatment in this patient? Yes, we should start the statin treatment, but what should be the treatment goal for this patient? That should be the question. So another case study, if we go about it, that 64-year male patient has history of diabetes and his HbA1c is 7.1. Lipid profile results are as follows. So as far as this report concerned, we have discussed internally and discussed this report with our internal physician colleagues as well. So by generalized feedback, we found that they are finding this report very normal one, and there is no intervention needed for this patient as far as lipid profile concerned. Um, so, do this patient need any intervention for the dyslipidemia? So, this kind of patient where risk stratification come into play, like statin therapy, which is given by many of the guidelines, and also Lipid Association of India also stating that treatment goal and considering therapy is has to be decided on the basis of risk category, and that is how we would like to understand how it will create the difference in these two patients. Like there are certain algorithms available for the risk stratification: flu risk, a lifetime risk model, full cohort equation, 10-year Framingham score. These are the all algorithm which is available to stratify the patient into the various category like low risk, high risk, moderate, and very high risk. But there are certain limitation with this algorithm. That is, none of them has been validated in Indian population, and also they are very complex algorithms, and which is not feasible for all to calculate the risk stratification by this algorithm. So in 2016, Lipid Association of India have published a guideline where they have mentioned there are certain ACVD risk factors, then other high risk features, and some non-conventional marker. And based on that, people can be stratified into various risk categories. So these are the major ACVD risk factors. One, that is age more than or equal to 45 years in male, um, more than or equal to 45-year female, family history of premature ASCVD, current cigarette smoking or tobacco use, high blood pressure, and low LDL. And apart from that, as earlier mentioned about and mentioned by Raman Puri sir, that high risk features like diabetes with 0 to 1 major ASCVD risk factors, CKD stage 3B or 4, familial hypercholesterolemia, and others like lipoprotein A available. So all by looking at all these factors, this patient has to be categorized into low risk, high risk, and moderate risk, and accordingly. So this risk category has already been mentioned by the SIR, and this is the by the Lipid Association of India 2020 guideline. Here we can see that low risk can be defined in patient where they are only having 0 to 1 major ASCVD risk, while if patient is having 2 major ASCVD risk factors or low risk group with more than or equal to 1 moderate risk non-conventional risk factor, it will be categorized into moderate risk category. And with more than or equal to 3 major ASCVD risk factors, it will categorize, he or she will categorize into high risk category. And pre-existing ASCVD, diabetic with two or more than 2 major ASCVD risk factors can be categorized into very high risk categories. So now we can understood that if patient is having suppose patient is having in high risk category, then the treatment considered drug therapy should be 70 milligram per deciliter for the LDL cholesterol. So any patient who is having high risk category and his LDL cholesterol is more than equal to 70 milligram per deciliter LDL cholesterol, then he should be started on the statin therapy. And the goal for this patient should be less than 70 milligram per deciliter. So now we again come back to the case that is mentioned earlier. The same case, the case 1, where we can see there are 2 major ASCVD risk factors in this patient. The one is the age and gender criteria, and other is hypertension history. According to that, patient is in moderate risk category, and we have to start statin therapy, and because the level of LDL cholesterol is more than 130 milligram per deciliter. And what should be the treatment goal for this patient? LDL level should be less than 100 in this patient. That should be his treatment goal. When we going for this generalized normal report that we are seeing, but here we can see that patient is diabetic, and also he is having 2 major ASCVD risk factor positive. One that is age criteria, and other is HDL cholesterol, which is lower on the lower side. So straight away, this patient is falling into very high risk category. And now this seems like normal report is something abnormal has been found. And we can say for this patient, the treatment goal is LDL level should be less than 50 milligram per deciliter. So that is how we should look into it. And that is how risk stratification can be helpful in many of the patients. And that is how we can prevent the heart risk as well. So we have built up algorithm with this major ASCVD risk factor in our lab as well. And after looking at the age, gender, and clinical history and lipid profile result, we are giving a report which is a personalized report to the patient. And if patient have achieved LDL cholesterol goal as per their risk category, then we are advising them they should monitor ApoB as the secondary treatment goal. So it is all from my side. If any question regarding that, yes.
Thank you, Dr. Modi. Any questions? Anybody? Quite good, I think, quite illustrative with the examples. I would just like to know, is LPA, small a, is in the horizon anywhere
Yes, sir.
as a risk
Yes, sir.
indicator?
Yes, sir. If we can see that by this slide, if lipoprotein A level between 20 to 49, then and if person is having 0 to 1 major ASCVD factor, so by 0 to 1 major ASCVD factor, he should be having low risk. But if lipoprotein A level is between 20 to 49, that and combined with the low risk, that will re-stratify it into moderate risk category. And if a lipoprotein A level is more than or equal to 50, then he or she will directly stratified into high risk group.
But I think it is not being used in the normal clinical
No,
practice.
not in the
Because
we
Indians are predisposed to premature atherosclerosis.
But there are patients
And
we are receiving the prescription.
Right, and it is postulated to be a marker of that.
But we are receiving the prescription.
Okay. Fine.
Sir, LPA is being used because now LAI guidelines are also advising that in Indian, especially high LPA level is very important, because otherwise when we see LPA level is advised as less than 30 as normal, but in Indians the guidelines are that less than 20 is more than 20 is considered high. So now LPA is coming, and like we offer panels where like LPA, ApoB is included. So many of the clinicians, they do ask for the entire panel to study complete lipid profile.
I think one group of subjects where LPA could be useful is, the young children of
Yes.
the patients
Yes,
who
sir.
already had MI, premature MI.
Yes, sir.
We had done some thesis like that, but I think it's not being followed by the cardiologists to evaluate the risk.
Yeah, so Dr. Anger also mentioned that LPA should be LPA and ApoB. Now they will come up with a guideline where at least once in a lifetime LPA should be done. We should know our LPA levels.
I think LPA has to be included in the lipid profile at least once in lifetime after the age of 18 years. It is now linked with premature coronary disease, death also. It has been associated with severe aortic stenosis. 33% of the people who are submitted for valve replacement, either for the TAVI or for the surgical procedures, had been evaluated and found that there is an increasing level of lipoprotein little a. So in combination with the ApoA moiety with the ApoB, it has got a pro-atherogenic, pro-thrombotic, and pro-inflammatory actions. So one should not forget about the implications of LPA. As per the Lipid Association, it is mandatory that everybody should be submitted at least once in lifetime for LPA levels. Serial testing of LPA after starting treatment with statin, not required. And LPA is not altered with your dietary modification or lifestyle modification. What are the medicines available to tackle this problem of LPA increase? There is no specific medications except to say that the PCSK9 inhibitor, the evolocumab, was tried in trials where it was shown that about 25 to 30% reduction of LPA with other parameters, thereby giving us an assurance that LPA probably can be controlled with the PCSK9 inhibitor. We are waiting for the FDA's approval for this particular indication. At this juncture, I would like to quote an example of my patient, a 39-year-old fellow who had sought advice for chest pain, acute coronary syndrome, post-PTCA. Gradually, the LDL levels were coming down with administration of high-dose rosuvastatin 40 milligrams with acetamide. Things were not becoming all right. He did not report in the next 4 weeks. He came after 12 weeks telling me that I developed a stroke. So 39-year-old fellow who developed acute myocardial infarction post-PTCA, and at the end of 8 weeks or so, he came back with a problem of right-sided hemiparesis with a stroke. That means he is going for a second event. So atherosclerotic event, if it is recurring, you need to think about LPA. So I did LPA only at that time, not in the initial stage, when the LPA levels were 180 milligrams. 180 milligrams. So I just suggested to him to go for PCSK9 inhibitor, which he could not afford. So these are the things what probably one can go on accumulating. In fact, I had seen association with the hereditary familial hypercholesterolemia. I got a set of patients in one family. All of them are having LPA in association with hypercholesterolemia. That shows it is a double burden of hypercholesterolemia with the LPA level increase, which probably pushes these patients for an early coronary event.
No, I think LPA in the baseline, LPA in the lipid profile would be a very desirable thing. Thank you, Dr. Modi.
Yeah, thank you, sir.
So
A very nice.
Thanks, Dr. Modi.
illustrated talk. Thank you very much.
Dr. Modi, please wait for a couple of minutes. I would like to call Mr. JP Meena onto stage to felicitate our speaker. So I'd like to call Dr. Reena Nakra onto the stage to felicitate our moderators for the third and fourth scientific sessions. And after this, we'll move straight away to the panel discussion part. Now I'll request Dr. Sanjay Arora, sir, to take the proceedings from here and start the panel discussion.
Okay. Good afternoon. Recently, I took up golf. I think I've always been inspired by Dr. Lal sir. I believe ma'am also is an avid golfer now. And I was told that, to make one good golf shot, you need to have 87 different variables. Correct me, sir, if that is right, that your foot posture and your back and your swing and your wrist movement and your finger movement and how hard you hold the club, etc., etc. I think the inputs that we have received today almost seems like, that getting a golf shot is like getting a perfect lipid profile. Uh, 87 different variables. I know there is lunch after this session, but after having heard most of the speakers, I think everybody will need to be on a statin after today's talk. I think lunch should only be soup and salad. All the desserts and all should be out. I think, pretty much everything is out of the menu today, right? And I've been closely working with JP and with Bharat. And I think one thing that I take away from Bharat, who's our CEO, he said, finally, okay, fine. He has these three alphabets called KKH. Karna kya hai? What really needs to be done? What is the take-home message for all of us? And I think to help us demystify, the sessions that we've had and try and give some sort of a take-home message, let me invite the panelists on stage. Dr. Iyengar, sir. I think he has already been introduced and already given a very wonderful talk on ApoB. The next panelist, Narsingan, sir, please come. Sir is the Managing Director of SNN Diagnostic Center and SNN Specialties Clinic Chennai. He's the Vice Chairman of the Lipid Association of India and a board member of the World Hypertension League. He has published over 74 articles and is a renowned personality in this area. Thank you, sir, for joining us. We have Dr. Raman Puri. Is he here? Sorry? He's joining us? Okay. And then we have Dr. Devki Nair, who's joining us online all the way from the UK. Thank you, Dr. Devki, for joining us. She's a consultant chemical pathologist and a clinical lead. Sorry, can I have the introduction back, please? She leads, the research for lipids and cardiovascular risk prevention. She has participated in the Department of Health. She also heads one of the regional services for cardiac biomarkers, and she's joining us all the way from UK. Thank you, Dr. Devki, for joining us. And we have Dr. Sadanand Shetty, who is joining us from Mumbai. He is the director of the Department of Cardiology, Somaya Super Speciality Institute. He's also the managing director and founder of Sadanand Healthy Living Center and founder of the CVD India and CCA International. He's the editor-in-chief, Cleveland Hall of Fame biography, and he is the national advisor to the Lipid Association of India. Thank you, Dr. Sadanand, for joining us online. So let me start with you. Dr. Nimi is, she's there all around, and come, Dr. Nimi, please join us on stage. Thank you, Dr. Nimi. Right. Thank you, sir. Thank you. She's the overarching presence for this entire session today, and she said, "Okay, I'll be there at the background," but I'm glad that she's with us. Thank you, Dr. Nimi, for joining us. So let me start with you, sir. So when you see a lipid profile report, and I'm sure in your extensive career, you must have seen so many of them, the lipid profiles have continued to evolve. So let me ask you a very take-home message question for the audience. What is your first look at the lipid profile? Is it looking at LDL? Is it looking at non-HDL? Or now, how often do you actually see ApoB? Is that a common parameter in most of the lipid profiles? And then what do we do with the older parameters like VLDL and the ratios? Should they even be reported going forward?
Yeah, I think you asked me a question after I spoke on ApoB. Yeah, anyway.
I actually added that.
I think as on now, we've been practicing that. Of course, we ask the lipid profile after going through, of course, the clinical examination history. I mean, I must mention here the things which are commonly forgotten in the history are, one is the family history, other one is about his physical activity, smoking and alcohol, etc. And here also I would like to emphasize, if it is a lady, we also forget to ask many questions like her menstrual history and the obstetric history, because these are some of the factors which are proved to be atherosclerotic cardiovascular disease risk factors, including, of course, sleep habits. Sleep is another good thing which has been implicated in the risk for atherosclerotic cardiovascular. So when you ask for the lipid profile, as we mentioned, LAI advises it to be done screening as a part of a global screening at the age of 18 years or 20 years, along with his height, weight, blood pressure, and sugar, etc. So when the patient comes with lipid profile, of course, first time screening, I will ask, as somebody rightly mentioned, non-fasting sample will do. And of course, we look at, as on now till today, is LDL cholesterol. And we don't have to wait for the lab to tell us about the non-HDL cholesterol. Though most of the labs are reporting non-HDL cholesterol on their own. So we look at LDL cholesterol and non-HDL cholesterol as on today. But we are introducing now LPA at least once in a lifetime. And at present, I'm doing ApoB only in selected cases for many reasons.
When going forward, do you think ApoB should become part of a lipid profile?
Yes.
As a standard
should become
parameter?
a lipid profile. And as I mentioned, it could be used for screening, diagnosis, and management. It could be used as a parameter.
Right. So just a continuation on that, and in my experience of having seen lipid profiles for almost 30 years now, very often I have seen when we do both LDL and ApoB, that LDL more often than not is elevated, but ApoB would still be, say, within range. Is that a similar experience in your scenario? And in this scenario, when you have LDL, which is slightly elevated, but ApoB is within range, does that still warrant starting a treatment?
Yeah, I mean, as on today, we go with LDL is the target, but I have not seen any reports where LDL is within the target or above the
LDL
target.
is elevated, but
and
ApoB is
low.
within the limits.
No, except one condition where I can think is the type 3 hyperlipidemia. It can happen. Otherwise, I don't think ApoB will be low.
Dr. Nimi, what has been your experience? You see thousands of lipid profiles every day. And when you look at LDL and ApoB, what's been your experience in that?
So generally, like LDL is high. Like even I would agree with sir that I haven't seen where LDL cholesterol is means vice versa. I have
Also
to say.
find that when
Yeah.
LDL is high, ApoB is
ApoB
also
is
raised.
also high.
Also
Yes.
raised. Rarely will you find that
Yeah.
only one is elevated and one is normal.
Yes, sir.
That's a type 3 hyperlipidemia.
Yeah. Yeah. So that.
Coming to you, sir.
And this is more a clinical question that, we all want to do a lipid profile. It's probably the most common prescribed test, and many people like self-prescribe the test. In your experience, especially with the incidence of sudden cardiac deaths, lower incidence of coronary artery disease, what has been your clinical correlation of HDL and LDL? I mean, do you always find that when you have a low HDL, more often than not, the patient will have, he'll come back to you with symptoms. Similarly, when they have an high LDL, will they come back to you showing symptoms of coronary artery disease? And between high HDL and high LDL, I mean, I know we have spoken about it, that LDL probably precedes as a, risk stratification, but what has been your clinical observation that do high and low values of HDL and high values of LDL, how do they correlate in your clinical setting?
I think we need to remember that we belong to the Asian Indian phenotype, which is usually characterized by high triglycerides and low HDL. Most of us will have low HDL. It does not mean that you've got a very high atherosclerotic cardiovascular risk. It is in association with other lipid parameters, which are going abnormal values. Probably it has got an implication, number one. Associated risk factors in an individual probably will play a major role, apart from the low HDL, what is being originally considered as the most important risk factor. Though we also had included it, it is not taken into consideration as a very serious problem. Even if it goes beyond 90, 100 HDL cholesterol, people think that no, we have 100 HDL cholesterol, so we will not get heart attack. It is not so. Probably it is a risk enhancer in those individuals who have highly elevated HDL cholesterol. And not only that, people who have very high HDL cholesterol have been seen to have some amount of cancer also. It has been reported. So I think based only on HDL cholesterol, probably we may not be in a position to come to a reasonable conclusion. Once when the LDL is elevated, it is all the more risky to consider that patient probably he has got an edge to develop a coronary artery disease in conjunction with other risk factors. The moment it is abnormally elevated, more than 180 milligrams, you think about the familial hypercholesterolemia. Maybe a homozygous familial lipid is more than 500. If more than 180 fellows are seeking advice at the age of 20, 30 years, maybe a familial hypercholesterolemia heterozygous type. Like that, now we try to divide. In case it is between 180 to 130 or 100 to 180, we always think it is probably environmental factors that increase this sort of increase in the LDL cholesterol, which requires our attention to start the treatment as early as possible.
Thank you, sir. Thank you. Dr. Puri, thank you. I think we have seen a lot of various new parameters being discussed today. While traditionally we report cholesterol, triglyceride, HDL, LDL, do you think there is a need to add additional biomarkers? So we discussed, I think you spoke briefly about HSCRP. We briefly touched upon LP(a), and we also have homocysteine. So could you share your thoughts that should these three parameters be also included along with ApoA1 and ApoB? Is there a need to make the lipid profile more comprehensive than traditionally? What has been the belief, as we were hearing that it's more belief and not evidence-based? Does the evidence suggest to make it more comprehensive?
Yes, I think that out of these three, biomarker, there is no doubt about high sensitive CRP, because even in our algorithm, we have kept high sensitive CRP as one of the moderate non-conventional risk factor if it is more than 2 milligram. And definitely, as I said before, that it has a prognostic value in patients who have an acute coronary syndrome. A persistently high CRP means they are more prone to have cardiovascular events. We have to be more aggressive in lowering LDL cholesterol in these group of patients. There is no doubt about lipoprotein small a, because it is atherogenic, and increases thrombosis and it causes inflammation. And this is probably one of the reasons for premature coronary artery disease in our setup. And we have recommended in our, recommendation that it should be a part of routine screening. Rather, we are the only association in the world who have recommended lipoprotein A assessment to be done at age 20, because majority of other associations said that once in lifetime, those who are in a high risk group of patients, you should do it. But we say because lipoprotein A is the level is genetically determined. 90 to 95% of this, it's a genetically based. So whatever level you achieve at age 5, probably it remains same unless there are some other problems like CKD and pregnancy and postmenopausal. So that should be definitely incorporated. Rather, I have already discussed with Dr. Nimi also that this should be a part of our extended lipid profile. Regarding homocysteine, there are no RCTs, there is no definite document that if I lower this, it is going to reduce cardiovascular event, because normally it is associated with low vitamin B12, 6, and folate, and lowering this by giving, folate and folic acid has not shown. So none of the recommendations, if you take other international recommendation and also LAI recommendation, we have not considered homocysteine as a part of that. We have no evidence for including this as
So it
one of
can't
the
show a
factors.
sort of a positive predictive value that if it is elevated, if homocysteine is high, if it is normal, you can say probably does not have a negative predictive value, but does it have a positive predictive value that if it is elevated, it could add to the risk?
Well, these are all observational and epidemiological studies, and based upon epidemiological and observation study, you cannot, formulate recommendations, So routinely, rather we have not put homocysteine as one of the risk marker in our recommendation.
Okay.
So, well, I don't know, because
We'd love to get experience. Yeah. So your experience and yours as well?
When you don't find any sort of risk factor in a fellow who has been admitted in ICU, it is not uncommon to see some people having the elevated levels of homocysteine. And finally, when the cardiologist gives a report at the time of discharge, he mentions hyperhomocystinemia needs attention. Fellow is prescribed some folic acid. Giving a folic acid, will it probably prevent the fellow to avoid another attack? We don't know. Hyperhomocystinemia induces endothelial dysfunction in association with the smoking, LDL cholesterol, physical inactivity, all those with LDL cholesterol, all these things try to probably increase the endothelial dysfunction and thereby probably aggravating the atherosclerosis. And we don't have any data to say that modifying it or lowering it, will it have any benefit in a person in whom it is really elevated?
And because I think the incidence of low vitamin B12 in our country is fairly widespread because most of the people are vegetarian. Maybe is that a contributing factor as well, that low vitamin B12, low folic acid, high homocysteine is the reason I was asking this question.
Even Inter-Heart study, in which was a population-based study, they identified 9 modifiable risk factors, in which we did not include homocysteine as one of the risk factors. So I think it will be premature at present to say that it should be put as a marker. But of course, it can be a individualized basis. If somebody has an experience of lowering it, if it does it, it's okay. But as far as evidence-based, answer is no.
Sure. So your experience with homocysteine?
Yeah, we routinely don't do it, but all my colleague neurologists do it. And in pediatrics, I think it is a well-established entity, and the treatment is there. As far as adults are concerned, we know that homocysteine is probably, based on the observational studies, increase the risk of clotting problems. Right? So, but treating it with folic acid and B12 will not give you result. So what is said is the homocysteine hypothesis has not been validated.
Thank you. And so you mentioned that LPA should be done once at least. What should be the frequency of HSCRP? How frequently should that be done?
See, you can for initial investigation, yes, high sensitive CRP should be included because it has a value in patients with low risk group and moderate risk group. It is not useful in patients who are very high risk group or extreme risk group or high risk group. But once that may be basis of starting statin also, because if low risk group patient has a high sensitivity CRP of more than 2, then definitely it becomes a moderate risk group. And in moderate risk group, we do not give trial of 3 to 6 months lifestyle intervention before starting statin. Because in moderate risk group, you should always discuss with the patient the benefit of statin versus not giving statin to bring down LDL cholesterol. So therefore, initially it can be yes, and for prognostic repeated, it can be, it is of value in patients with acute coronary syndrome, and you treat it, whether it comes down. And if it is more than 10 milligram, then it possibly is a acute phase reactant. So you have to repeat it after 4 to 6 weeks after treating that subclinical infection. Rather, if you look into the mean high sensitive CRP in Indian population, various studies have shown that mean is around 1.7. 1.8. So what exactly should be the value for Indian population? We don't know. Rather, this 1.7 or 1.8 milligram of high sensitivity is also said to be probably responsible for premature coronary artery disease in Indian population. So therefore, I think it is important, and it should be done at least once. And until unless you think that to see the prognostic part, whether it has come down or not with the statin, because normally statin cause about 30% reduction in high sensitive CRP. So that can be there. Otherwise, I don't think that it can be done as routinely.
I think apart from statin, I think I need to mention about the use of bempedoic acid, which is a recently introduced drug, has also shown reduction of high sensitive CRP. Even the icosapent ethyl ester, one of the omega-3 fatty acids, which was tried in a reduced trial to concentrate on triglyceride reduction and the cardiovascular outcome in people who already reached LDL goal, has shown a reduction of high sensitive CRP. Probably that has got a multiple pleiotropic effect, icosapent ethyl ester. One of that is this high sensitive CRP reduction, whether that has shown maximum benefit compared to the other group, which did not show benefit.
I think,
I think there are more advanced inflammatory biomarkers coming up. A lot of clinical trials have been done, starting with Paul Ritkus, what he did, which was a negative trial. But now with the colchicine study has been done. Cantos was a negative trial. And so
I think Sir spoke about interleukin 6.
I think there will be.
I think, sir,
there are
I
better
think
inflammatory markers than.
I think that it is very important inflammatory marker, because if you look into Improve IT trial and Jupiter trial, both these trials, the maximum reduction in cardiovascular event were in those group of patients in which the LDL cholesterol achieved was less than 70 milligram and high sensitive CRP less than 2 milligram. So the maximum benefit was seen in those, not even those patients with LDL less than 70, but high sensitive CRP more, was having a more CV event as compared to those with low LDL and no high sensitivity. So we have now enough evidence based upon Colcut trial and all that Cantos trial that reducing high sensitive CRP is beneficial.
Dr. Nimi, I think we have spoken about the challenges when we don't have the background of measuring HSCRP, and you mentioned that. I think Dr. Puri also spoke about it, that if it is an acute phase reactant, it can be falsely elevated. So in your experience, what has been your views on measuring HSCRP, and how can we see that over a period of time, that if it is consistently elevated or if it is just 2 or 3, what's been your lab experience on that? So would you like to add to that as well?
I'm sorry, I don't.
No, maybe Dr. Nimi can start at the idea was about, you spoke about HSCRP also overlapping as a acute phase reactant sometimes,
Right.
at least in the Indian population, because of the high incidence of inflammatory and infectious disorders.
So it's ultimately CRP what we are measuring. It's only when we are very low level of CRP, we are able to detect that that's what we call as high sensitive CRP. So many a times we find CRP levels which are more than 10 milligram per liter. So they are clearly, if the levels are so high, there has to be some underlying other inflammatory cause which need to be ruled out. So ideally, at least HSCRP should be repeated 2 to 3 times to decide the baseline. And if it's high, the one high level should not be taken as a risk marker. It should definitely be repeated. That's what.
Thank you. Thank you. Let's involve our two speakers who have joined us online, Dr. Devki first. So Dr. Devki, we have been hearing that high risk for coronary artery disease is a multifactorial. So there is lifestyle, there is environment, but there is also the role of genetics. So can you give us your experience in the UK? And, I was reading up that there are over, 100 different biomarkers for various conditions related to the heart. Do you in the UK use genetic biomarkers routinely to make the lipid profile more comprehensive? What has been your experience of using genomic biomarkers to make lipid profile more comprehensive? Dr. Devki.
Thank you, Nemi, for inviting me. And I can see there are, many people who have joined. I hope there are biochemists among who will pick up some of the biochemistry aspects to improve our knowledge in India about the biochemistry of lipids and biomarkers and make them interested in doing some research. Then going to your question, that's a really interesting and a very good question. In UK, fortunately, we have access to genetic testing for familial hypercholesterolemia on the NHS. So if we suspect that anybody has FH, we have access to genetics. Other than the monogenic disorder, which is the familial hypercholesterolemia, we do not use any other genetic marker for cholesterol. In patients with high triglyceride, we also have access for ApoE genotyping, which again is used. And do we find this is useful? The genetic markers, the genetics. The monogenic FH, it's useful especially for patients who come to us with a diagnosis of familial hypercholesterolemia to screen the relatives so that we can intervene early, because most of our FH patients may come to us too late. And therefore, it provides us an opportunity for cascade testing. So cascade testing is very well established in UK. We have a national system where we have a program called a PASS, which connects several lipid clinics so that we can pick up patients from different lipid clinics for genetic testing. The reason why this is so important for us is because genetic testing on an index patient costs about £400 for us. And if you do in the relatives, it's only £60. So we have a network of lipid clinics who work together. For example, if I have a patient in London and the children are in Manchester or Birmingham, we can get in touch with the team at Birmingham or Manchester or wherever, so that we can do the cascade testing, which is less expensive. Otherwise, Birmingham will spend £400, Manchester will spend £400. So this is something which happens in UK with the familial hypercholesterolemia. ApoE genotype, we do ApoE genotype for managing patients. And as you all know, ApoE genotype is important to diagnose type 3 hyperlipidemia. It's an autosomal recessive condition. So we don't do cascade testing as we do for the autosomal dominant condition, which is familial hypercholesterolemia, where 50% of siblings and 50% of the children may be affected, so that we can pick it up. Autosomal recessive, you have to have 2 genes. Therefore, we don't do cascade testing, but it does help us, especially that these patients present with high cholesterol and high triglycerides. And we always find they respond better to a fibrate than just the statin. Although statin is also important because these patients have a very high risk for developing heart disease. It's only 1 in 10,000, the prevalence, but the ApoE genotype of 2-2, they inherit an ApoE lipoprotein phenotype, which is 2-2, which has a slightly different amino acid, which doesn't clear the remnant cholesterol from the circulation. So we also do the remnant cholesterol in a different way so that we can pick up the beta VLDL, which we called as a floating beta test, which helps us to confirm the diagnosis of familial hypercholesterolemia. So these are the genetic markers which we use in 2 of the conditions. We also have access to lipoprotein lipase genotyping, the lipoprotein lipase and all the other 5 genes associated with LPL, ApoA5, ApoC2, etc., which is also, again, NHS provides that support, so patients don't pay for it, and we don't pay from the department as well for that. So therefore, these patients' inherited problems are managed well. So other than that, we don't do any genetic markers. Then going on to this monogenic and the polygenic hypercholesterolemia, we have in research that the polygenic score may be useful in patients, in differentiating a monogenic from a polygenic cause. And the polygenic score is not difficult to calculate. If you do a genome sequencing, you're looking at all the LDL genes, and so they can calculate a score from the genetic lab and give you. But the evidence from UK on polygenic score is mainly from the Whitehall study, which is consisting of all white patients. So now recently, what we have done is in looking at the Asian patients, but the polygenic score doesn't work as well as it should, as in the white population. And we also replicated this study in a small group of patients in Kerala, as one of the Lipid Association members who is doing a PhD on lipids, is done a small group around 120, and we see this discrepancy from the Whitehall study in the Asian population. So I'm not too sure that we will be using the polygenic score in Asian patients. And people who do not know what is a polygenic score, it is, to simplify it, is that you have the SNPs in the LDL genes, different LDL controlling genes, which you add up. And if you add up all that, you get a higher LDL cholesterol. So you're looking at the 12 SNPs as in the Whitehall study, and some of the studies looked at 6 SNPs, which control the LDL cholesterol concentration. So these are about the genetics. And I think we have to watch this space, whether this is going to be useful for the Asian population.
Thank you. Thank you.
Then moving on to the markers, biomarkers, what do I do routinely in a lipid clinic? I do measure lipoprotein little a, but lipoprotein little a is not available for the cardiologists or the general practitioners. They have to come to the lipid clinic to have it measured. The reason being, treatment of these is giving a statin. There's nothing else is available as yet. But in future, when we have the drugs directed at the lipoprotein little a, probably this will become a marker which is measured by everyone, including cardiologists and general practitioners, but we don't measure that. ApoA1 and ApoB we measure once in lifetime for all our patients. We don't repeat the measurements. Other than that, lipid profile, a full lipid profile, and I have to shamefully say that we know that the Fried-Wald equation is not good, but we all still report Fried-Wald's equation, the LDL calculated value. We haven't again made any change to that. The reason being most of the clinical trials are done with the Fried-Wald's equation. As you know that above 400 milligrams of triglycerides, Fried-Wald equation is useless. We now recommend through the NICE guideline using an alternate equation, the Sampson and the Martin equation. Martin equation has not been tried for triglyceride of over 400 milligrams, but the Sampson equation has been investigated in patients who have triglycerides above 800 milligrams. But direct LDL is the best one in all patients who have a high triglycerides. The lower limit of detection is around 4 milligrams, so you can measure really low level of LDL by measuring the LDL, even in those patients who get ultra low LDL levels. So I don't think we need to worry about that in India because you have access to LDL levels, your direct LDL levels for everyone. So I don't think we need to worry about these equations. We don't have the LDL measurement, direct LDL measurement at present is only with the specialist clinic, and we haven't rolled it out to the general practitioners or to the cardiologists because we're still the Friedewald equation centric for general use. We talked about homocysteine. I do homocysteine on selected patients when patients present with normal cholesterol, no risk factors are found, and sometimes the genotyping is done by the hematologist because they do the clotting factors and they may have a genotype MTHFR, gene which increases the homocysteine. They end up in the cardiovascular clinic for managing. So we manage them more aggressively rather than ignoring the homocysteine. Otherwise, we don't measure homocysteine regularly. That is.
Thank you, Dr. Devi. I think we'll come back to you. Thank you for your inputs. We have Dr. Sadanand Shetty, who's been patiently waiting for us. So I know the access of genomic testing, is always a challenge, but fortunately, with the network that we have at Dr. Lal Path Labs, it's becoming more and more accessible and affordable. Also, we have seen, Dr. Shetty, that once you start statin therapy, it is almost lifelong. In your experience, have you started to use pharmacogenomics, which will identify a responder versus a non-responder, somebody who's likely to get more side effects versus not? What is your experience on the use of pharmacogenomics before you start statin therapy?
Anyway, thank you. And before answering, I would like to thank LAI and Lal Path Lab for making such a very important and very useful program. And I couldn't make it personally, though Dr. Raman Puri requested to attend due to logistic reason. And I must thank Nimi for continuous work behind this session. To tell you frankly, pharmacogenomic testing we don't do routinely. That one thing I would like to mention very clearly, unless in some specific situation where we get into statin-induced myopathy or statin-related or associated muscle symptoms, then there may be a place. Now, basically, as you asked, pharmacogenetic basically means the genetic profile we want to find out, and how the pharmacology or the medication like statin can change. Like it can change the absorption, the action, that's called pharmacokinetic effect. It can have an effect on the pharmacodynamic, that's a drug action. Idiosyncrasy of a particular drug, like statin, when we put in some patient, there could be, though it is more common in anti-malignant immunosuppressive therapy, but at times even in a statin therapy, etc. Now, there are some genotyping which have been sort of identified, like SLCO1B1 is one particular gene, which is a transfer gene has been found, wherein probably doing that study before starting the statin, we could probably anticipate whether this patient is going to get, the statin-associated muscle symptoms or not. But at least my personal experience and, the doing this, these genes before starting therapy, I don't know, unless my other panelist, member, maybe Devaki could answer that, how it is relevant to our practice. But now once you are giving us in Lal Pathology, Path Lab, I think probably we may make use of it if it becomes like a cost effective. I must also compliment Lal Pathology, which I mentioned, Dr. Raman Puri, that in our reporting, LAI consensus statement is put in every report. And that's a very good, welcome change, and that's what we need to, as a for the patient to know what is their target they should reach, etc.
Thank you. Thank you. Sir, just coming back to. No. Sir, one question for you is, in your clinical experience, what is the adherence of statin therapy? Do people, stop it on their own because of non-specific side effects? And you spoke about, inflammation of the muscle weakness or myalgia, myositis, etc. So, do you find what's been your experience overall on the adherence of lipid lowering agents today?
Yeah, I mean, in my modest practice, I think the adherence has been good in my patient population. But when we look at the overall population in the country or the global population, the adherence to statin therapy is very poor. It needs to improve. There's much needs to be done. Even in Western countries, I think the adherence has been a big problem. So all we need to do is I think patient education, and very rarely we need to discontinue statin therapy.
Okay. And sir, in your experience, we spoke briefly about alternate therapies. Can you share some thoughts on how are there some emerging, therapies that are coming out which are alternate to statins, which could be used in people who have side effects?
In fact, no. If you look at the statin intolerance, globally it has been projected as only 9%. The latest data tells you there is only 7.2% of the people who receive statin, they develop true statin intolerance. Most of them will come back to the doctor saying that I got muscle pain. It does not mean that he has developed some sort of side effect due to statin and you need to stop the drug. No, all my patients who seek advice for the muscle pain, in spite of the fact that I tell them in advance, you are likely to get some muscle pain when I start this drug, don't come back to me. Suppose they come back to me at the end of 2 weeks or 3 weeks. Again, I convince them that he should continuously take it because the beneficial effects are more in that individual for whom I had prescribed. So that is the most important thing. I think the one-to-one interaction between the doctor and the patient is the most important thing to have a good amount of adherence as far as the statin therapy is concerned. So true intolerance is rare. Only 7.5% of the patients in population has been found out to have this sort of true intolerance. Many of them will have only the placebo effect or the nocebo effect. And people who were saying that muscle pain, when they are all given placebo, they did not develop it. Again, they were switched over to statin. They said, we don't have pain at all. So that means they were all trying to imagine that there is a problem. Because most of the people who receive statin, they try to contact their children in United States or UK. They try to Google it and say, Daddy, you have been prescribed this particular drug. Don't take it. It will produce myalgia. You will go for renal failure, statin intolerance, all sorts of things. Go back to the doctor, tell him to stop the drug. I had the experience of probably talking to my patients' relatives like that. I think these are the things, and the Google is the one that is spoiling these people. Number one, and all the people who are critics about statin usage, they also try to have their own platform to criticize that the lipid lowering is not required. Cholesterol is required for the normal functioning of all cells for the brain function, and it may produce cancer if you start taking statin. All these misconceptions have been going on in rounds and rounds. I think I had seen many people sending the WhatsApp messages to the doctors, to the healthcare providers repeatedly on these issues. I think that platform is now creating trouble for those people who are taking statins, and many of them stopped, including the doctors for whom we prescribed. They come back and tell, sir, I stopped it because there is a Google message saying that it is not a good drug. So I think adherence is important. One-to-one interaction is important. The beneficial effects have to be probably explained to the patient in a situation where he really requires this particular drug for him to have a longevity prolonged.
So let me just ask a little pointed question to all the panelists. Do you take statins yourself, sir?
It's a valid question.
Because we have to practice what we preach, I guess, So.
Not necessarily, because I'm just telling you. I'm just telling you, age is one factor. Of course, I crossed that age of 55, as we have already underlined. I don't have diabetes. I have what I can say elevated blood pressure, not even stage 1 as per the American guidelines. I am not a smoker. I give company to Dr. Iyengar only for alcohol, very rarely. Very rarely. And when I calculate the risk is only the lower risk. I calculate the JBS3 to identify whether I have an increased lifetime risk score, whether it is more than 30 or less than 30. It is less than 30. So I don't require statin. Thank you.
Dr. Puri?
Yes, I disagree with Dr. Narsingan in this way. Because you never know that the coronary artery disease, when it manifests, you may have subclinical atherosclerosis.
Yeah.
And that manifests at any time. And I started statin about almost 25 to 30 years back. And when my LDL cholesterol was somewhere in 90s. I am not a hypertensive, I'm not a diabetic, not a smoker, and I walk about 10,000 steps every day. Even then I take, because I know that if I reduce my LDL cholesterol by 40 milligram, from 96 to say 54, I reduce cardiovascular event by 22%. And if I reduce it earlier, see, there have been a study in which if you reduce LDL cholesterol of 40 milligram for 5 years, you reduce event by 22%. If you reduce 40 milligram for 12 years, your event reduction is 32%. If you reduce it by 50 years, event reduction is 53%. So I don't think that I will like to keep terrorists in my blood, which can create problem anytime. So I'm a very strong advocate of statin and LDL cholesterol. According to me, all of us should have at least less than 70 milligram. And if somebody keeps at less than 50 milligram, I will never stop him. I will never say against that, because I know that it is going to benefit him in long run.
Dr. Sethi, what's
Yeah.
your LDL?
Yeah. Though I may look young, but my look is deceiving because I'm just entering into age of 70 now. And I agree with Dr. Raman Puri. And, unfortunately, I've got everything little. I've got diabetes, I've got dyslipidemia. And of course, recently, 7 months back, I suffered PE. That's a part, pulmonary embolism. But I do take, and my LDL is around 50, triglyceride less than 100, pressure about 120/80, weight is around 68, 1 hour regular walk, so fine. Weight, so I'm maintaining here. I agree with Dr. Puri, and in this regard, keeping our lipid, particularly the LDL less than 50, being a diabetic for last 3-4 years.
Thank you. I'll end with you, Dr. Iyengar. Since you started, you can end. How do you manage your lipid profile as a take-home message for all of us?
I also walk 10,000 steps per day. So I do exercise regularly. I do take moderate alcohol in the company of nursing. And unfortunately, I have non-obstructive coronary artery disease, as shown by the CT coronary angiogram. So I take statins, and my LDL cholesterol is 45 milligram.
And you have no side effects of statins?
Definitely no, yeah. Except when you take little extra alcohol, myalgia comes up.
Yeah.
Dr. Om is more concerned with that, I think, And do you recommend CT angio once every 10 years?
No. We don't recommend CT coronary angio. We have regular protocol for everything. CT coronary angio, we don't recommend. It's only in patients probably who refuse to undergo coronary angiogram. If there's an indication for coronary angiogram, do the conventional coronary angiogram. If somebody is not willing to do it, then CT coronary angiogram.
Sure, thank you. I know there is a lot that can be discussed, but for shortage of time, don't focus on lunch, focus on the panelists so you can catch them and, have more questions with them. But I want to thank Dr. Devki, Dr. Sadanand Shetty, Dr. Vijayan, all three of them who have been patiently with us, all the panelists on the dais. Thank you so much. Thank you, Dr. Nimi, for arranging a wonderful session today. Thank you so much.
Thank you. Thank you, Devki. Hi. Fine.
Hi.
Fine. Hi, Vinod. Okay,
Everyone,
fine.
thank you all.
Hi. Okay, fine. Okay.
Yeah, thank you, Dr. Sanjay sir, for putting up such important and clinically relevant questions for this panel discussion. And I'd also like to thank all the panelists for sharing their views, including their views on their own treatment and management of their lipid profiles. So I would like to now call this session to be ended with a following up of uh, trophy distribution ceremony, basically. So I would like to request Dr. Sanjay sir to felicitate our panelists. First, Dr. Narsingan sir. Dr. Iyengar sir. So Dr. Narsingan sir has a flight to catch. So next, I will request Dr. Sanjay sir to felicitate Dr. Iyengar sir. One more as a panelist. Next, please, sir, Dr. Raman Puri, sir. Thank you, Dr. Puri, sir, for your informative talks. Yeah, ये भी होगी. So, the rest of our panelists who have joined us online, Dr. Shetty and Dr. Devki Nair. Sir, ma'am, will be sending across your mementos.
Thank you.
And now I would like to request Dr. Om Manchanda, sir, please come for a concluding remark and vote of thanks. Please. Dr. Sanjay, sir, please join us. Dr. Manchanda, sir, will felicitate Dr. Sanjay, sir. What do you say?
Good afternoon, everyone. And I know I'm standing in between lunch and all of you. I'll be very, very quick, maybe a couple of minutes. And first, I want to thank all the speakers and panelists. It was an absolutely fantastic sort of a 3.5, 4 hour session. I actually thought I was watching a documentary on cardiovascular, hooked onto television. I think it's excellent knowledge, at least I gained in last 4 hours. I'm sure all of you would have done that. As all of you know that this whole COVID and sudden cardiac death is talk of town, and many WhatsApp group people are talking about this. In the last 3-4 days, lots of messages have been floating around. I think it's a responsibility of all of us, including diagnostic labs, to create awareness in the society. And I think that's the least we can do. As Dr. Sanjay quickly whispered in my ear that I'm going to convert to statins for tomorrow, and I think I'm going to do it today itself. So that's the power of knowledge which can bring change in the society. Few things that I gathered from these sessions that I just quickly summarize and probably as a thing that we take home. One is genetics, which is given to us. We can't do much about that. Second important thing is about lifestyle. I think we can do a lot about this. and create awareness and bring that change in our families and friend circle. I think the last message, which is very important, is the regular monitoring. While I think I read a very interesting line yesterday. I think Dr. Lal, you forwarded that just because you feel you're fit does not mean you are actually fit. So, which essentially means you need to monitor your status. There was somebody else who had written that just because you've climbed Mount Everest twice in a year does not mean you are actually risk-free. So you still need to monitor, need to test and figure out what it is. I think the data that my team has shared with me, and I find virtually half of the population is with one or two risk factors in our society. Is that correct, Reena? So which means I think a lot of us will have to create that awareness. Second thing I found was that the LDL is very important. I didn't know that actually there's one more thing, which is ApoB we have to figure out. And I kept looking at my all past reports of last 10 years. It looks like I'm okay on that. Then I also found that non-fasting is a music to our ears. And I kept thinking whether it's a good news or a bad news. The good news is that operationally for us, it will be a very easy thing to do because we don't have to actually insist fasting. I don't know if there are some lab people staying there. I was whispering to this Dr. Anuj that does it mean you will keep the customer with you now, the patient with you, not let them go to private labs the next day morning? He says, yes, that's what we are trying to do as well. So I don't know which one is good or bad. So net, I think it was a wonderful sort of 3.5 hours of session. And once again, I want to thank each one of you to be here with us, and also more importantly, speakers and the panelists. Thank you very much. And lastly, I want to thank our team as well, Dr. Nimi, Dr. Ratima and the team, I think, and Dr. Veena. All of you have put up a great show. Keep it up. Thank you.
So with this, we are at the end of this scientific session, the CME on lipid profile and knowing our heart, improvising heart health. So I request everyone to join us for lunch. Lunch is open.